All right, everyone, since it's 9:03, we will go ahead and get started. Let me just make sure we have everything set here. Okay, thank you for joining us for the Health IT Leadership Roundtable on the promise of virtual technology to transform patient care. We are pleased to have members of Congress, administration officials, and an esteemed group of private sector panelists to share their thoughts on the opportunities and challenges for healthcare data and healthcare technology in a post-COVID world. Obviously, over the past year, a lot has changed, but a lot has also stayed the same. And so we look forward to hearing from our panelists and other speakers about their perspective on where we go from here and what priorities should be for 2021. Before I introduce our first speaker, I wanted to share a brief overview on the Health IT Leadership Roundtable Initiative, preview the agenda, and address a few housekeeping items. The purpose of today's event, starting with the Health IT Leadership Roundtable overview, is to bring organizations with a variety of different perspectives together to talk about our shared commitment and roadmap for achieving high-quality healthcare for virtual care. Let me see if I can just advance through the slides here. This event is the third Health IT Leadership Roundtable, with the first held in January 2020 and the second held in July 2020. Today's event, as you can see here on the slide, is brought to you in partnership with a host committee of organizations from across the healthcare system, representing patients, clinicians, hospitals, health plans, and technology companies. I want to thank each of these host committee members, many of whom have been very active in helping shape our event and identify panelists, and thank them for their commitment and to a collaborative cross-sector dialogue on key health IT issues of the day. Next, before we go too much further, I want to take a look at the agenda. So we, as I mentioned, have a really jam-packed agenda for the next 3 hours. I will just briefly turn it over to Justine Handelman from the Blue Cross Blue Shield Association in a few moments. She will be followed with a congressional keynote from Senator Bill Cassidy, and then we will hear from Mickey Tripathi, the National Coordinator for Health IT. After that, we will move into a couple panels focused on data infrastructure and fostering emerging technologies, and then we'll do a deeper dive on patient access and trust. That panel will be followed with a second congressional keynote from Representative Peters, and then we will wrap up with the closing keynote from Cincy Hernandez-Cancio from the National Partnership for Women's and Families. So we, as I mentioned, have a jam-packed agenda. We will do our best to stay on track and make it through everything in the next 3 hours. I also need to address a few housekeeping items. So you can see here on the slide, we will be tweeting about the event from the handle @HIT Roundtable. Please follow us there for key takeaways from today's discussion and for important announcement after today's event. One of those announcements will be when the recording is available. So we are recording today's event and we'll make the recording available on the event landing page as soon as possible. That event page can be found on the Sirona Strategies website. And you can see the website address there. Additionally, several of our speakers will be taking Q&A. As I mentioned, we do have a jam-packed agenda, so we may not be able to get to all the Q&A during the time we have today, but we will certainly do our best. If you have questions, please put them in the chat function, and we will either answer them during today's event or in the chat feature itself, or follow up afterwards, just sort of depending on what time allows. Please also watch the chat and poll features on the menu bar. We have a couple polling questions teed up if time permits. So we'll kind of guide you through that, but would love your participation as the opportunity arises. And then finally, I wanted to note we do have some members of the press joining us today. If you're a member of the press and would like to follow up with any of our panelists or any of our host committee members, please contact Melissa Quick at the address here. I think that's it for as far as housekeeping. I wanted to next introduce our first speaker for opening remarks, Justine Handelman. Justine is Senior Vice President of the Office of Policy and Representation for the Blue Cross Blue Shield Association. In overseeing BCBSA's lobbying and policy development activities, Justine represents BCBSA's Washington office and BCBS companies with the administration, Congress, government agencies, and other national associations. She has more than 25 years of experience in providing strategic analysis, policy development, and federal representation on legislative, regulatory, and federal policy issues pertaining to public and private healthcare. During her tenure, she has developed key policy positions that were incorporated in legislation enacted by Congress on key healthcare issues, including the Medicare Modernization Act, the Affordable Care Act, legislation to prevent opioid abuse, and legislation to address mental health parity. Please welcome Justine Handelman.
Thank you, Kristen. And good morning, everyone. It's really great to be here with you for the third time. We're just grateful to have you join us today for this important discussion. I know we're now a year into the pandemic, and I think folks feel a lot of Zoom fatigue, but really appreciate everyone coming together because this topic is certainly top of mind for the entire healthcare industry, from patients to health plans to hospitals and clinicians. Really, how can we fully harness the power of technology to transform patient care? The Blue Cross Blue Shield Association is thrilled to partner with our esteemed colleagues on the host committee that Kristen shared with you today on our Health IT Leadership Roundtable. So I want to thank you all, the host committee, and Kristen for making this happen. We came together, as I mentioned, this is our third, we came together around a shared belief that appropriate and secure use of technology can provide important tools to transform healthcare in this country and really to improve the patient experience and their ability to get the care they need. Just a little bit about the Blue Cross Blue Shield Association. For those that might not be familiar with us, we are a national federation of 35 independent, community-based and locally operated Blue Cross Blue Shield companies that collectively provide health care coverage to 1 in 3 Americans. And we provide that coverage in every market and every zip code across the United States and Puerto Rico. And as community-based health insurance providers, we really see firsthand how the COVID-19 pandemic has impacted the people we cover and the communities we serve. This past year has impacted all of us in so many ways. We all know how our lives were abruptly disrupted a year ago, and we've become more physically distant over that year. Yet it's been technology that's really allowed us to come together, whether it be to continue to connect with family and friends, with our loved ones, to carry on our day-to-day work, and importantly, to ensure that the patients can connect with their doctors and their healthcare providers. So we've learned so much in this last year, and we really now have a great opportunity to harness the power of technology to truly transform patient care in a meaningful way. So I'm super excited for the discussion that will be taking place today and the work that will come out of this to really drive transformation forward. As we discussed at last year's Health IT Roundtable, our twofold shared objectives really remain the same since then. First, we want to deploy technology in a safe and secure way. That's so critical to the consumer and the patients that we serve. And second, we must continue to advance innovations that expand patient access to the right care at the right time, where and when they need it. Over the past year, we've seen telehealth utilization increase substantially, as has other digital forms of health technologies and tools. Local health departments, pharmacies, primary care providers, plans, and others have worked to build new connections and new partnerships to deliver care, to support patients in new ways, and to exchange data more effectively and securely. So as tough as this pandemic has been, there are some good things that have come out of it in terms of the advancement of technology to improve patient care. And though we've seen improvements in technology, health IT, and data sharing, and it has helped bridge many of the gaps that exist, we all know there are still gaps that exist and more work to be done. So again, really appreciate the coming together to help solve collectively. Another thing the pandemic has exposed in terms of gaps in our healthcare system, are the challenges we've faced in collecting, sharing, and reporting public health data, as well as data around COVID-19 testing and vaccine distribution. And that data, as vaccine supply increases, is just going to be critically more important. We know many, including states and the federal government, are calling for a 21st century public health data system that can better support interoperability and data exchange, which we know all too well right now is so important. The COVID-19 pandemic has also magnified longstanding health inequities to tragic proportions. I just want to share a few statistics that have been out there, but they're really staggering and worth reminders. People of color contract COVID-19 at nearly 3 times the rate as whites. Black mothers have 3 times higher maternal mortality and 2 times higher morbidity than white mothers. The prevalence of delivery complications is 46% higher among Black mothers versus white mothers. African Americans are more likely to suffer from diabetes and cardiovascular disease than white Americans. And health insurance coverage also varies by race, with Blacks 1.5 times more likely to be uninsured and Hispanics 2.5 times more likely to lack coverage compared to whites. This simply cannot continue, and we must address the disparities and inequities that exist in our system today. Blue Cross Blue Shield plans have been working to promote health equity and reduce barriers to good health with culturally appropriate community-based interventions, from targeted interventions to improve maternal health outcomes, to expand access to behavioral health services to help prevent and better manage diabetes and heart disease, to supporting the growth of a more diverse healthcare workforce, which is just so important to also addressing these disparities, improving access to coverage, and harnessing the power and data of technology, which we all know can play a role in advancing health equity. Public health and social determinants data is just essential to better identify disparities and to address gaps in care. That's why we appreciate the administration's executive actions recently that seek to address some of these concerns. For instance, President Biden's executive order ensuring equitable pandemic response and recovery established a COVID-19 health equity task force to advise the president on ways to mitigate health inequities caused and exacerbated by the pandemic, and to prevent such inequities in the future. The task force is specifically charged with addressing data shortfalls on COVID-19 infection, hospitalization, and death rates, as well as underlying health and social vulnerabilities. President Biden also signed an executive order earlier this year that requires federal agencies to enhance their data collection and to collaborate on capabilities to improve the efficacy of public health data systems, and importantly, to advance innovation in public health data and analytics. These efforts by the federal government will help coordinate federal resources and responses across industries. We've also seen action and leadership from across the healthcare system, from all of you that are joining and from our host partners in leveraging technology and data to address the vaccine effort, with a keen focus on making sure that people in vulnerable communities can get vaccinated and get vaccinated in an equitable way. And along with these efforts, we're providing innovative and consumer-focused solutions to improve access to care for everyone. BCBSA and our Blue Cross Blue Shield plans have been harnessing the power of technology and data in the national fight against COVID-19 to reach vulnerable communities. Just last week, we signed the National Rally for Recovery Commitment, which is a public-private pledge to protect employees and encourage COVID-19 vaccination, and also educate staff and local communities on ways to mitigate the spread of the virus. Blue Cross Blue Shield, along with America's Health Insurance Plans, AHIP, and our colleagues across the the payer industry also announced a new pilot initiative last week aimed at accelerating COVID-19 vaccinations where distribution has been inequitable. We call this new pilot initiative the Vaccine Community Connectors, and our initial goal is to help vaccinate 2 million people who are 65 and older in America's most at-risk, vulnerable, and underserved communities. And we're really excited to be part of the solution and to scale that work. Though a key issue we must address to make sure that all Americans can get vaccinated in an equitable way is having access to standardized vaccine data in both federal and state immunization registries. Especially data right now is necessary in our outreach efforts to vulnerable communities. Today, health plans face challenges in getting access to information on who in their membership has received a COVID-19 vaccination. So state and federal registries are really critical, as is the IZ Gateway, to allow plans to conduct targeted outreach to those members who have not been vaccinated to help them get a vaccine. We know right now that approximately 25% of those vulnerable seniors that we are targeting, when plans do outbound calls to reach them, we're being told they've already been vaccinated, and that is great. It's great to know, but we just don't have the data right now to know, because often claims are not being submitted since the federal government is paying for the vaccinations. So that's why access to these registries is so important. And time is really of the essence to reform our current policies to enable seamless, interoperable vaccine data access in a standardized way for all of us to do our part in expediting and enabling COVID-19 vaccinations for all Americans, and really all vaccinations beyond COVID. One thing I'll point out that data, data, as I think we all know, can also serve as an early warning system. And we've seen over the last year in our own data an alarming drop in childhood vaccinations. So knowing that, we can reach out and make sure that children are getting vaccinated. Again, critically important, we've been able to eradicate diseases like polio and measles due to those vaccinations, and making sure, because of the pandemic, folks that have not wanted to take their children into healthcare settings, given the risk of exposure, we need to make sure that we can educate and get them vaccinated in a safe way. So as we meet today and discuss the challenges, there really are solutions to make sure that we can better measure the impact of local health equity interventions by improving access to accurate demographic information, which currently is also not standardized nor easily available in an accessible and secure way. BCBSA has been a founding member of HL7's Gravity Project, which is a really important multi-stakeholder initiative that's working to accelerate the movement of social determinants of health data throughout the healthcare delivery system and community-based organizations using modern-day health IT API standards. We believe a national health policy effort should focus on promoting health equity and addressing the needs of vulnerable and underserved communities, as I've said. And we can do this by developing national standards for how we collect and use secure demographic health information, and by ensuring that appropriate healthcare professionals have seamless, interoperable access to this information. As we all know, throughout the pandemic, virtual care technologies, including telehealth, have demonstrated how technology can enable patient care, challenging us to reimagine how healthcare could be delivered in the future. As the nation continues to grapple with the pandemic, policymakers, providers, health plans have taken extraordinary steps to expand access to virtual care. BCBSA and the Blue System has been leveraging technology-driven solutions such as telehealth and virtual care to meet patient needs. For instance, last year, Blue Cross Blue Shield companies committed more than $7 billion in the fight against this pandemic by providing premium relief, enhancing access to telehealth services, and investing in support people need. We were able to expand telehealth because federal and state policies allowed flexibility around existing restrictions on the use of telehealth in the United States. Historically, telehealth utilization has been greatly limited by statutes and regulations, including restrictions on technology, patient location, existing provider relationships, or type of allowable service. And the pandemic has shown how innovative and powerful telehealth transformed the way we access care. To continue this transformation that we've seen, not only for telehealth, which really is the tip of the iceberg, but for all forms of virtual care, we must identify and remove regulatory barriers to expand access, enable flexibility and coverage, and ensure that consumers trust the privacy and security around those technologies. These key policy issues will be foundational as cutting-edge virtual care tools such as artificial intelligence, behavioral nudges delivered through wearables or other technologies, self-triaging, contactless technologies, who knows what else. The innovations out there are just extraordinary and will become commonplace in the near future. And although we're seeing significant innovation and it's going to continue to occur, it's undeniable that to realize the promise of all of these new innovations, policy barriers must be addressed right now. And in the immediate need right now, really see three things. One, collectively, we need to determine what technology, data, and quality standards look like in a virtual setting versus an in-person setting to enable interoperability to harness the power of data. Second, to ensure privacy and security is as secure and safe as needed, we need to ensure that the framework for privacy and security is aligned to HIPAA. HIPAA safeguards for technologies that move sensitive information, for the use of tools, apps, and wearables. And third, we have to make sure we have the necessary technical infrastructure to manage various data inputs and create a clear picture of a patient's health with information from a variety of sources. We all know care delivery is going to look very different in the future, and we are pleased to come together today with all of you who are leaders from across the healthcare system to collectively reimagine ways to improve care delivery through innovation, take advantage of the opportunities being created by health system transformation, and identify and address potential policy challenges early on. The speakers today represent patients and consumer advocacy groups, community-based organizations, providers, health plans, health IT experts, and policymakers. And the keynotes, as Kristen pointed out, and panels are going to touch on really important issues such as consumer trust, data and technology, infrastructure advances, and progress during the pandemic. And also, what are the opportunities that we can harness as we look to the future? So we look forward to a groundbreaking discussion. We appreciate everyone's participation today. I hope it is an active discussion where lots of questions are asked, because those questions really drive conversation and help us bring forth solutions. So again, just want to thank you all for your hard work and dedication to this important issue. So with that framing in mind, Kristen, unless you tell me otherwise, I would love to introduce our next speaker.
All right, let's take a pause here. Do we have Senator Cassidy? We have a mystery panelist that might be Senator Cassidy. So I think I'll just take a pause, Justine, and go ahead and ask a polling question while we get a little bit situated here. So the first question is just really a, sort of get to know our audience better kind of question. We would love to know with the folks that we have here in attendance, what your role is in the healthcare system, and whether you are, as you can see from the options here, whether you are a patient or a patient advocate, a payer, physician or physician representative, hospital or hospital representative, government official, consultant, or other. We know that there is a wide range of folks here, and we appreciate that, because that was actually, the goal of the event, to bring together disparate perspectives from across the healthcare system to focus on areas of alignment and identify really shared opportunities and shared challenges where we can all come together to support consensus-based solutions. So I will just allow this poll to go for another minute or two while we wait for Senator Cassidy, and then Justine, we will have you introduce him as soon as he joins.
Great.
All right, it looks like we have Senator Cassidy here. He maybe just looks like stepped over to close the door. So Justine, I will go ahead and turn it back over to you to introduce Senator Cassidy. Thanks for joining us, Senator.
Thank you.
Great. Well, thank you, Senator Cassidy, to be here with us today, and I'm really honored to introduce you. We all have the Honorable Senator Bill Cassidy of Louisiana, someone who I think we all know well. Senator Cassidy joins us today to discuss how secure access to data and technology can help improve our response to the COVID-19 pandemic and advance patient care. We all appreciate your leadership, Senator, in our shared battle against COVID-19 and finding ways to harness the power of technology and data to improve patient care. As you may already be aware, Senator, Blue Cross Blue Shield of Louisiana partnered with the Louisiana Public Health Department to develop the Louisiana COVID-19 Outbreak Tracker, which has helped state officials track, predict, and simulate the potential and actual spread of COVID-19 in the state. Again, our theme today, harnessing the power of technology and data to improve healthcare. As a physician, Senator Cassidy knows all too well the inequities that exist in our healthcare system and what's needed to ensure patients get the right care at the right time in the right setting. He is a tireless advocate for improving our healthcare system and ensuring better patient outcomes while enhancing consumer trust. Senator Cassidy grew up in Baton Rouge, Louisiana, attended Louisiana State University for undergraduate and medical school, and in 1990, he joined LSU Medical School teaching medical students and residents at the Earl K. Long Hospital, a hospital that provided care for the uninsured. And during that time, he also co-founded the Greater Baton Rouge Community Clinic, a clinic providing free dental and health care to the working uninsured. Senator Cassidy also created a private-public partnership to vaccinate 36,000 Greater Baton Rouge area children against hepatitis B at no cost to the schools or parents. And in the wake of Hurricane Katrina, the senator led a group of healthcare volunteers to convert an abandoned Kmart building into an emergency healthcare facility, providing basic healthcare to hurricane evacuees. In 2006, he was elected to the Louisiana State Senate, was elected to the U.S. House of Representatives in 2008, representing Louisiana's 6th congressional district, and in 2014, he was elected to the U.S. Senate. Today, he serves on the important Finance Committee, the important Health, Education, and Labor Pensions Committee, very important Energy and Natural Resources Committee, and importantly, the Veterans Affairs Committee. So Senator Cassidy, we all thank you for your leadership and for joining us today, and I'll now turn to you.
Thank you, Justine. I appreciate it. You ever feel like whatever you're talking about is going to be so dramatically different if you talk about it again in a year? And this is the juxtaposition of privacy with technology. And there's a tension. How do we use big data or technology to improve patient care? But how do we not sacrifice somebody's privacy in a way in which we would not wish our own privacy to be sacrificed? And some of this stuff I'm sure is being done, but could you imagine, as one example of a artificial hip, which has sensors that feels the pressure within the hip once it's placed. And as it is moving, it can alert the clinician whether or not that hip is having problems, whether or not there's physical therapy that needs to align the muscles so that the stressors on the hip are more the way the artificial hip is built as opposed to that which is already occurring, on and on. But you could also get location data out of that. You could also get a history of falling. Oh, this person's falling all the time. Do they have a neurologic condition which is developing, such as Alzheimer's, which is causing them to fall more often? You could imagine it would simultaneously measure pulse, maybe even blood pressure or blood sugar, because there's blood flowing around. You could somehow attack that. That in of itself should be protected health information. But would it be? Under current law, is it? Those are the questions we have to ponder. And what we're looking at right now is just a vista of possibilities. So it all comes down to the question, how do we balance the incredible benefit of technology and health IT with the incredible threat it has to an individual's privacy? Congress doesn't have the answers. And I think but it is the place where we need to have forums like this in which people such as you and others can bring your ideas and hope we find that answer which benefits us all. Now there's other issues as well. Let me just say, not just that tension, but I'm looking at some notes and just to say as well, who pays for it? There's a lot of stuff out there that we know would be beneficial, but again, it has to be paid for. And if you're going to limit use, do you have a business model which can pay for the infrastructure absent the monetizing of somebody's personal health information? If you think of the big tech companies, Amazon, Google, and Facebook, their business model is monetizing that which they learn about us, and they learn a heck of a lot, including things that in a doctor's office would be considered protected health information. So can we have a business model that doesn't require that sort of surveillance, but which still pays for these new innovations? So how do we protect health data? And it begs the question, is HIPAA still relevant? Of course it's still relevant. If I'm taking a note from a patient and she tells me that she is concerned about her husband's alcoholism, well, that's protected health information, even though it pertains to her husband. But we have to recognize that there's things that you can, as a surrogate, learn about the patient or her husband. For example, a smartwatch telling you that the patient's husband regularly goes to a bar or a liquor store, and that sometimes when he is walking home, he falls, and he comes at home at 2 a.m. And when he comes home, his car goes back and forth. You could then correlate that with the public record showing that he's been stopped and checked for DUI, all because a smartwatch tipped somebody off as to where that person went and how long they stayed there and their condition when they left. Now, really, that should be PHI, but instead it could be easily gathered by someone using a smartwatch integrated with the other forms of information which they are receiving. I could go on. I was once told that things such as benign prostatic hypertrophy, which affects every male roughly beginning at age 35 and worsening with age, if that smartwatch tells whoever owns the data that the male is getting up 5 times a night to go urinate, I bet you their BPH is problematic. Should we somehow integrate that data into how we price a product to him? Should we hire somebody whose online searches or whose other information we gather, however we gather it, indicates that they have an interest in diabetes or an HIV or an artificial insemination, which is a very expensive procedure? Because if we hire them, that may increase the premiums that we're paying for our health insurance. So I do think that is important. Now we're just on the advent. Imagine that we have somebody going to some data bank of gene therapy, which not all of them are protected. Some of them have the permission in that kind of thing you check off saying you agree with the privacy agreement to potentially monetize your data. And it's not just your data, because if my blood relative has my same gene, it's their data too. So, should I hire this person with a genetic defect for which I may be required to pay for gene therapy, and which in case would increase the cost of my health insurance premium, as another example. So I do think we've got great promise, but we've got great threat, and we have to think about that very carefully, or we will undermine the public's faith in that great promise. Now, I'll point out, I'm using examples that we're familiar with. A smartwatch, seeing how many times somebody gets up at night to urinate, following their location data to say where they go, how long they stay, and what time of night they leave. That's now. That's now. We are so behind the curve. If what we're talking about in a year is still this, we're really behind the curve, because we should have been talking about this 3 years ago. So there is a kind of sense of urgency we should have as we attempt to address this. Now, by the way, FDA has traditionally regulated products, not systems. And so, and what if you have an update? Now, we don't want to slow innovation. Smartwatches can be incredibly helpful. I count my steps on my phone to encourage me to get a certain number of steps per day, knowing that my location data is being tracked as well. I tolerate that infringement for that which otherwise encourages me to exercise. But FDA has to figure this out. How is it going to regulate systems, and what is it going to do with updates? It can't be the slow pace FDA normally has, because software is constantly being updated. Now, we will find perhaps, though, that in some cases, even if FDA makes a decision for some devices, a payer's decision will have just or even greater a role. Imagine if we have artificial intelligence, and the artificial intelligence gives decision support to a clinician, but the clinician is allowed to override the system per the FDA's approval. May be that a payer decides they don't want an override to occur, or they put such obstacles in place that the override cannot occur. So that is one of those tensions that we have to work out to realize the promise, but to also recognize that there would be exceptions, but the exceptions may be quite exceptional. There's just layers of things we have to understand going forward. Now, I do think the COVID pandemic has forced upon us some of these considerations sooner than we otherwise would have thought about. Telehealth, huge advance. And initially, people were using FaceTime because they didn't have the telehealth integrated into their EHR. Some did, but some did not. Well, that's been worked out. And as that's been worked out, the cost of telehealth has also been decreased. And now we have money allocated for states to build out rural broadband so that telehealth can reach its potential, going out to areas where there may not be as many physicians, but perhaps with telehealth, we can meet some of those needs. That is just fantastic. And I think of a practical application. My practice in Louisiana was in a hospital for the uninsured. Louisiana has a significant problem with maternal mortality. Unfortunately, we're the worst in the nation. So you have somebody in a rural area, an African American in the rural area, high risk for maternal mortality, and she's at risk for preeclampsia, which is to say high blood pressure in the third trimester. I have no doubt that Louisiana Blue Cross Blue Shield would pay for the telemonitoring that would allow this person in the rural area to have her blood pressure monitored remotely, so that her clinician, wherever her clinician is, Alexandria, Louisiana, would be able to follow her blood pressure and her weight to see whether or not there was fluid building up, to see whether her blood pressure was climbing, and whether or not she would have to come in sooner. You could even imagine, knowing that her transportation may be challenged, that something would be set up to go out and bring her in because we knew that she was going to have a problem. So we see all this promise. She has to be secure that this blood pressure cuff is only going to her doctor and no place else. Now we can say that will be covered by HIPAA. Of course it will be. But if there is this atmosphere of distrust, because other things have been exposed as monetizing her information, it may destroy the trust even in the privacy systems we have now. So I'll end by saying we've got great promise. We just got to guardrail that promise in a way which treats others as we would wish ourselves to be treated. To apply the golden rule to the issue of privacy as we realize the promise of big data, because that promise of big data is an obligation we owe not just to ourselves, but to future generations. There's a lot at stake here. Justine, I don't know if I have time, but would love to take a question or two.
Great. I think we do have a couple minutes, and we did receive some questions. So we have a question about employees and COVID information. What about employer use of information with respect to COVID?
Isn't that interesting? First, we know that employers can require a certain, can either require that someone be vaccinated, and if they're not vaccinated, that they take precautions that you don't have to take if you are vaccinated. We know that because healthcare facilities will do that with the flu vaccine. And I believe I know that current federal guidelines are that if knowing this information is important for the health of the employee and for the health of others, either in the office or those whom the employee serves, that would be that the employer can know that information. Now, of course, I'm not a lawyer and I'm speaking off the top of my head, but it makes sense to me because that's what we do with flu shots. If you're not vaccinated, you have to take precautions that someone working in the hospital who is vaccinated does not need to take. Now, on the other hand, I'm a big believer, and the science proves that if one is previously infected, one is most likely immune. So even if you have not been vaccinated, my wife never believed me, but there's an article in the New York Times saying that today, so maybe she'll now believe me. That said, the only other reason I could see an employer making use of someone's COVID status is if they see that they've been previously infected, they could still ask them to be vaccinated, but at least have a higher level of comfort that the person would otherwise be immune even if they were exposed. I don't know if the questioner had another thought besides that. Kristen, you're on mute.
Oh, sorry about that. Yeah, I think we can follow up separately. There's a question about post-COVID long haulers. So not just the immediate COVID, but also those that feel the effects. And so obviously that's another type of clinical situation and data about a patient that's out there now. Now that we have had the pandemic.
Yeah, I think we need to have some definition of that. When I had my COVID, my sense of smell and taste did not completely return to normal for months, but now it has. On the other hand, that was my only symptom. And I may have met somebody's definition of a long hauler, but practically speaking, I could return to my normal activity. That's quite different from others who apparently are quite clinically affected. So it does seem as if, and there is money that Congress has allocated to do more research on long haulers.
Great. And then I want to wrap up with just one more question. This is a perfect segue, I think, into the rest of the event. Your whole remarks really have been, since we'll be exploring the tension, sort of inherent and the need to and desire to use data, but then, use it appropriately. The last question here gets to something that you touched on, which is, given that there are so many types of information not covered by HIPAA, what do you think Congress does next? And do you think Congress should pass a federal privacy law?
I do think Congress should pass a federal privacy law. It's a wild west out there. And people are establishing standards that just based on a business model. Again, there's a certain amount of genetic material that is being processed in China. Think about that. The most personal information I have, if China came in and stole my records from the Office of Management Personnel, whatever, whatever the personnel budget is, as I think they already have, we would be righteously outraged. But if somebody takes my genetic information and then applies it to that big data set, shouldn't that disturb me even more? Again, and that's not just my information, but every blood relative, my children, my brothers, et cetera. So I think, now, not to pick on China, because others could use the same thing, and it is certainly not limited to genetic therapy. By the way, my wife could pluck a hair off my head and send it off for gene analysis. And I don't know that she's plucked that hair off my head, or perhaps a hair off my coat. I don't know that I don't have to give her permission. You can collect genetic material from someone without their permission and still get it run. That's wrong. I should have control over that data. We need to have better controls over that data for the individual.
Great. Well, thank you so much for joining us. As I said, I think your remarks are a perfect segue into the rest of the event, where we'll further explore, the trade-offs associated with, the use of data technology. So we really appreciate you being here today and sharing your thoughts.
Thank you, Kristen. I appreciate being with you.
Thanks. All right, so now we will go ahead and have a little bit of a transition here. So let me just get my screen shared. The next item on our agenda is to touch on, let me see here. We're going to transition. So obviously we just had remarks from Senator Cassidy, and let's see. Now we will move into the administration portion of the event. And again, I'm just working on sharing my screen here again. So as we move through, so we just had Senator Cassidy. So I mentioned we're transitioning to the administration portion of our Health IT event. I know we have Mickey Tripathi, the National Coordinator for Health IT, who has joined. Just briefly before we launch into the portion of the agenda where Mickey will provide remarks, we did want to sort of just provide some framing and level set on the Biden administration's Health IT priorities. So obviously, over the past few months, everything is being looked at through a COVID lens. Many of the Biden administration officials, from President Biden on down, have been on the record on issues that are relevant to the topics that we're discussing here today. So we pulled together just a really short video, which I will hopefully play now, to sort of recap some of those remarks and provide some framing for Mickey's remarks. So if all goes well, it should play here for just a moment, and then we will turn it over to Mickey. Let me see what's happening here. Did we freeze up? Right. Let me try one more time. If it doesn't work, we will just move on. Let's see. All right. They are telling me the audio is not working, so I think we'll just give up. We'll just give up and surrender to the technical difficulties. And Mickey, if you are on, which I think that you are, we will just go ahead and turn it over to you. We can make this video available separately on the website. So Mickey, we'll just go ahead and turn it over to you. I will introduce you just briefly. So Mickey Tripathi, as I mentioned, is the National Coordinator for Health Information Technology. He leads the formulation of federal health IT strategy and coordinates federal health IT policies, standards, programs, and investments. He has over 20 years of experience across the health IT landscape, most recently serving as Chief Alliance Officer at Arcadia, a healthcare data and software company focused on population health management and value-based care. He was the project manager of the Argonaut Project, a board member of HL7, the Sequoia Project, the Commonwealth Health Alliance, and the Caron Alliance. He also served as the president and chief executive officer of the Massachusetts eHealth Collaborative, a nonprofit health IT advisory and clinical data analytics company. He has done many other things. So he was also the founding president and CEO of the Indiana Health Information Exchange. And he holds a PhD in political science from MIT. So we are pleased to welcome you, Mickey, and look forward to hearing about your priorities as national coordinator and where you think the administration will focus its health IT efforts going forward.
Okay, great. Thanks so much, Kristen. Thanks for the invitation and really delighted to be here. I want to first off commend your bravery in trying a video in a session like this. I did get a chance to look at the video in advance, so I would definitely recommend that others take a look at it once it's available.
I don't know if it was bravery or stupidity, but got to give it a whirl.
It's like doing a live demo when you're a software company.
Right,
it's like, all right, let's give it a try. No, but I really appreciate it and really delighted to be here. And certainly, following on Senator Cassidy's remarks, which are always, really interesting. So I thought I would just talk a little bit about, sort of break up the, the discussion of ONC priorities into a couple big buckets. One is thinking about the Biden administration priorities, which apply to all federal agencies. I mean, it's not just ONC, which is, as Kristen mentioned, is, job number one is COVID right now. That is the top priority. So we've got a lot of work going on there that I'm, happy to describe in a second. And then I'll talk about, sort of the other work that we do, because ONC had a pretty full plate, even before, before the pandemic hit and, ongoing throughout the pandemic. We still have a bunch of things that are, that are very important, we think, for the industry and that we are moving forward. So none of that slows down, in my view. We need to work on that in parallel. So with respect to COVID, a couple of things. One is that we are supporting all of the work related to the execution of the executive orders. As many of you, no doubt saw, there have been a number of executive orders that were issued by the White House, and we are working alongside our colleagues in the Department of Health and Human Services, as well as other agencies, to staff work groups that are associated with, with each one of those executive orders. One of the things that on the outside of federal government that I didn't fully appreciate is that every executive order actually has real work attached to it. Someone actually has to do that. Now, on the inside, I realize that now. It's like, oh, okay, we actually have to do those things. Not that we don't want to do those things, but there's actual work now to make sure that every single one of those is hitting the mark in terms of the priority, the urgency, the importance of it, and the execution of it. So we are, supporting a number of the work groups, 7 or 8 of them, and then we are also co-leading one, which I think is a really important one, with the CDC that's related to public health data systems. So you may have seen, there's one of the executive orders is called, I think it's something like ensuring a data-driven response to high threat emergencies or public health emergencies. I think I'm paraphrasing, that's not the exact words, and one of the sections of the executive order calls for a review of interoperability and connectivity related to public health data systems. So we've launched a work group that, as I said, we're co-leading with the CDC and working in very close partnership with them to take a look at, what have we learned from this epidemic, this pandemic, and how does that help inform what the gaps are, what the uses have been of the public health data systems that are in place today. And I think, as many of you may know, they were very much stretched to their limits. In many cases, we were trying to, because we had to, use some of those public health data systems for things that they weren't originally designed for, which also taught a lot of lessons, I think, along the way. So we'll do a lot of work there, identifying what was the system performance, what was the original intent of those systems, how did they actually perform, what did we learn from that in terms of gaps? And then how do we think about the future of public health data systems, which I think, that's a very important executive order, and one that that we're really delighted and excited to be working on. As I said, that just got launched, but we're digging in earnest now. The second thing I would point to, which is certainly an administration priority, and it's a general administration priority, as well as a priority in as we think about COVID and as we think about health IT, which is health equity. And what I like to think about when we think about health equity is thinking about health equity by design, which is to say that we shouldn't, as we are right now, I think, and and this is just a matter of time, and views evolve and things evolve, but in many areas we have embraced technology, moved forward with standards, with processes that didn't explicitly take into account the consequences that our actions and activities might have on health equity. And that's, and then you catch up later and you sort of do some measurement and you realize, oh, wow, this created some health disparities. We didn't realize. Now we have to go back and, rectify and mitigate. What I think we all need to work on and move toward, and certainly within ONC, we're doing our best to do this, is thinking about health equity by design. From the very beginning, saying, what are the health equity considerations here, and how do we bake that in as a fundamental design criterion so that we have fewer surprises down the road? There's always surprises, but it should be a surprise because of perhaps something that we didn't plan for or was unintended, but not because we didn't explicitly try to make an effort at the beginning to think about health equity. And that cuts across the board as we think about the way standards are developed. When we think about the granularity of social determinants of health, race, ethnicity, and language data, what are the workflows associated with getting that data? How do we do that in a way that protects privacy so that people don't have concerns or don't have hesitancy about giving their information if they have the confidence that it's being used for purposes that will ultimately benefit them? And also, as we think about, the new technologies that are coming to bear, I think everyone's familiar with the issues with algorithmic bias, and and that is a bigger and bigger issue as we think about the more that algorithms are embedded in in all the technologies that we use. So health equity by design is a key priority area for us, and one that we are going to be focusing a lot of attention on. We're also involved in a number of other areas where we're working with our federal partners to think about approaches as they have health IT implications, or health IT as a part of what we need to think about there. For example, vaccine credentials, or vaccine certificates, as people call them, as we have something like 10% of the population having had their full complement of vaccinations now. That number is growing rapidly, as we know. And I think, as anyone who's been following the press knows, that there is a question both within the U.S. as well as in other countries, as well as a global sort of perspective on the idea of being able to offer proof in some way of your vaccination status as a public health measure, and to be able to resume to people's day-to-day activities. So we're working with our federal partners on just sort of understanding the landscape and trying to sort of best evaluate what are the various considerations there, and how do we work with our federal partners on thinking about that. And as you can imagine, there's a lot of health IT sort of pieces of that are of particular importance to ONC. So that's just in a nutshell is the work that we're doing in the with respect to COVID and the current pandemic. There's a lot of other things related to that pop up, but we're spending a whole bunch of time on those things. As I think move now to thinking about the other areas that we're focusing on, I like to think about these as sort of kind of an orchestration of levers, because when you think about what any federal agency, and certainly the National Coordinator's Office, we have a set of levers, a set of things that we can use to help to influence the market in certain ways. And some of those are hard levers, and some of those are sort of softer levers. And the hard levers are things that are direct result directly from from something written in statute that then turns into a rule, for example. So we're working very hard on information blocking. The applicability date of April 5th is just around the corner. So we're doing a lot to make sure that we're reaching out to the market, that we're providing education, providing outreach to the market so that the market is best prepared to be able to meet the applicability date of April 5th. So we're very much looking forward to that, and we're working on FAQs that I think, as I had mentioned yesterday, will be a next round of FAQs will be released next week, and that's in the ongoing effort to be able to answer people's questions so that they are as prepared as they can be for that April 5th date. I think one of the important things to to recognize about information blocking is its importance, because at the end of the day, all of this, I think, as we've learned with the internet, it's all about platform economics. It's all about supporting an innovation economy and being able to support open platform sort of approaches to things. I think is one thing that we've learned is where we can get great value from the inter-based types of businesses and clinical orientations that we can have. But we need protections as well, and so that's a little bit of the balance. I thought Senator Cassidy always offers great insights into sort of the issues related to opening up more and more to a platform type of approach, and I think very nicely articulates some of the real key issues that need to be addressed there. The other thing I think that's really important for us to just recognize about information blocking is that it's a little bit deeper than a lot of the other regulatory activities that we've had in the past from an ONC perspective. It's more deeply ingrained. It's attacking things that are more deeply ingrained in sort of the organization culture of providers, vendors, health information networks, and and others in the healthcare delivery value chain. And so we just have to recognize that this is going to take time, and it's going to be something that that people are going to sort of move toward, and we certainly recognize that. But on the other hand, it's something that needs to be taken seriously, because it does get more at the heart of the way organizations think about information sharing, which is fundamentally different. And so therefore, it requires much more serious consideration, I think, up and down the organization about how to deal with information blocking. So we also have a set of what I think of as soft levers. Sorry. One thing I want to mention about information blocking is we also have the associated EHR certification. So I think, as many of you may know, a very important part of moving all of this forward is not only the things that we want to be able to do with respect to policy, but also making sure that the technology is keeping up with that and is allowing the providers to be able to do the things that are going to contribute to the type of of safe but liquid interoperability that all of us want to be able to achieve across the healthcare delivery system. And so EHR certification is a really important part of that. And though some of those dates got pushed out, it's still very important that that we have the FHIR specification being a requirement for the technology vendors, as and that is a real fundamental aspect of being able to open up the technologies to the kinds of applications and the kind of interoperability that we want to be able to see in a future world. So that's in a way that those sets of things are kind of our hard levers that we want to push on to make sure that we've got the regulations going, that the regulations are responsive to industry needs, but are also stretching all of us to to keep moving forward. But one of the challenges with regulations, I think, is that regulations by design don't happen overnight. Those are things that require a lot of deliberation, require a lot of input from industry to make sure that we're striking the right balance, and then they go through review cycles and they get released at a certain pace. And in a fast-moving world where technology and business processes are changing on the fly, it's one of the challenges in the technology area where we're working, where the regulations in some ways are always going to be a little bit lagging. In terms of the pace at which change happens. So we try to be anticipatory in some ways, but on the other hand, we also don't want regulation to be what sets the pace of progress. And that's one of the challenges I think that we have as we think about the certification rule and the dates related to certification. That one of my concerns is I don't want the industry to wait until the last minute to implement the things that are going that we know are all a part of where we want to be. And so, there's certainly a tendency, which I understand, where everyone's got priorities. And so you look at that date for, when certain things are required, and then you put all of that, into the lower priority, and you get there next year, or you get there the year after. What I'd like to do, and what we're thinking a lot about at ONC, is how we exercise soft levers to try to encourage the industry to move forward and to keep moving forward incrementally, so that we're not having to wait until those regulation dates to be able to get the benefits of technologies that we know are available, but that are being sort of implemented in a heterogeneous way, and sort of according to individual timelines, rather than sort of being able to move forward as an industry. So we have a number of things that I kind of put in the category of soft levers. Obviously, one is what I'm doing here today, which is the bully pulpit, being able to just encourage people to to keep moving forward, and to keep working with with the standards bodies and with your implementation communities, and whether it's fire accelerators or others, to keep moving, keep making sort of the use cases and the associated standards and implementation guides real, and focused on things that are important for for your customers and for your stakeholders, but that keep us moving forward, and don't sit and wait for a regulation to require it. And a part of that also is, aside from the bully pulpit, that has some value, but limited value, is a couple of other things that we put in place. So one is thinking about nationwide interoperability, and in 21st Century Cures, as many of you may know, there is the TEFCA, which is a part of that. Why do I call that a soft lever, since it's written in the statute? Well, right now, in some ways, it is a soft lever, because there's no requirement that anyone participate in TEFCA. So one of the things that that we're focusing on as we think about TEFCA is how do we have that balance in an approach that's going to be attractive. I mean, it's got to be something that is attractive to the industry, to voluntarily want to be able to participate in that, for for all the benefits that a solid network provides. And there are many, many examples in other industries, as well as in healthcare, and as we think about nationwide interoperability networks, where there is voluntary participation, there is sort of motivation to be able to do that. And one of the challenges, and I think the trick for us, as we think about TEFCA, is how do we add value with with sort of a layer of governance and collaboration that adds value to the overall system, and helps to motivate it, to help to finally settle some of these questions of different types of networks at different geographies that cover different types of use cases. How do we sort of stitch those together in some way that's going to make sense, and that's going to be durable over time? We don't want something like that's going to be brittle to individual business use cases, and we also don't want it to be an additional tax on on organizations and providers and technology vendors who already sometimes have 2, 3, 4 types of interoperability mechanisms. They might have to pay, whether it's hard dollars or effort, in sort of supporting those different things, which not only creates market confusion, but it's a real cost. And we don't want TEFCA to be yet another cost on top without clear and obvious benefit to whatever cost is required to be able to participate in that. I'm not talking about financial cost. I'm talking about just even the effort of participating in TEFCA. So that's a lot of what we want to be able to do, and spending a lot of time thinking about that. We have other things that I think are really important as well, as we think about these these soft levers, and we're thinking a lot about how do we orchestrate these. So when you think about the standards version advancement process, for example, which is a sub-regulatory way of allowing people that have certified health information technology. So if it's a certified EHR technology certified by ONC, that has met a certain requirement with respect to standards, as I think we all know, those standards keep getting refined and keep getting reviewed, and keep moving forward. And what we don't want is for that to be cast in stone, because the regulation, and certification says, well, this is the standard you use. It's this implementation guide. So the SVAP process allows people to voluntarily move forward as new versions of those standards that are approved by the Secretary of Health and Human Services, but as those get updated, so that they don't have to, so that we don't have to write a new regulation for people to be able to move forward. And it allows the vendor community to keep moving forward as they see fit voluntarily within the certification that they have. So that's a really important thing, I think, is for, while by itself it seems small, but I think it's a part of a fabric that keeps us all moving forward and allows the flexibility for us to, to allow people to move forward without, having to have a new regulation or, go through a very large new process. The US CDI is another, mechanism for us to be able to, sort of provide some guidance, provide a little bit of, foreshadowing, a little bit of, motivation for the industry to move forward in certain ways. And for example, as we think about, sort of the US CDI as being a rising floor of data that we want to be able to have as sort of that structured, base that everyone can count on when they do interoperability. We know that there's going to be a lot of variation by provider organization, by by vendor, by instance, that'll vary according to what is available. But we want to be able to make sure of is that everyone can at least have the expectation of getting the US CDI data in a way that is structured enough for them to be able to do the work that they want to be able to do. And we want that to be a rising floor. So the US CDI, I think, is a really important way for us to be able to signal to the market, here are the things that we think are important, and here are the things that ultimately could become a part of regulation. Everything in the US CDI looking forward doesn't necessarily become a part of regulation, but but that's part of the balance that we'll try to strike, and we want to work with industry on as well. Importantly, that also excuse me. Importantly, that also is an important part of the next sort of soft lever I want to talk about, which is a lot of time and effort that we're focusing on cross-agency coordination within the federal government. When I was outside the federal government, I didn't give or have full appreciation for both how much work it is to have the capital C role of the National Coordinator's Office, the focus inside the federal government, not just outside the federal government. And that is it's an extraordinary effort, I think, to be able to do the kinds of things that we want to be able to do to get all of the parts of the federal government sort of rowing in the same direction. And increasingly, as health IT becomes a part of what many agencies are doing as they start to roll out technologies and start to see the value of the kinds of things that these kinds of technologies can offer, that raises the bar on our ability in ONC to be able to work with them, to be able to say, how do we make sure that that everything that you're doing is taking the best advantage of the standards and of the the approaches that we've taken, so that we can help every one of those agencies better accomplish the things that they want to accomplish. And often it's just an outreach and communication, because sometimes it just isn't full awareness of the things that that ONC has already rolled out, and sometimes it's just a more just firm alignment of kind of a better understanding of what we have anticipated going forward and how we align that with those agencies' interests. So we're spending a lot of time working on that. And the US CDI, for example, is one example of the kinds of things that come up in those sorts of conversations. As a CMS or a CDC or a VA or any number of other agencies think about the kinds of things that they want to be able to do. You think about the research community with NIH and FDA, the kinds of things that they want to be able to do and the kinds of data that they'd like to be able to get. One place for us to be able to move that forward into a broader set of use cases is thinking about the US CDI and how that can be a vehicle for saying, what other types of structured data do we want to be able to make available so that we can have those kinds of use cases that that create sort of the foundation for a better, more interoperable world serving multiple needs. So we're spending a lot of time, as I said, on working on coordination with our federal partners, exercising a vehicle called the Federal Health IT Coordinating Council, which has been in existence since 2014. But we're doing a lot of work now to try to sort of elevate that to be able to have it focus on very specific areas that can can help sort of bring to bear that cross agency coordination in a way that will hopefully be more effective going forward. A couple of other things that I would just tick off. I mean, one, I think I just wanted to again just mention, and especially since I just saw the tail end of Senator Cassidy's comments. I mean, I think the whole privacy area is obviously extremely important. And as I said, I think he flagged, just from what I saw, all of the issues that he flagged are really important issues for us to sort of contemplate. Obviously, that's not something that's directly within ONC's sort of jurisdiction, but we obviously also have a lot of stake in how we think about privacy going forward outside the realm of HIPAA, with respect to the APIs that we are requiring that be put in place in EHR technologies that enable patients to be able to have access to their data in ways that cross the border of the HIPAA boundary. So we obviously have an interest in that and want to make sure that that all is that reflected in the way we think about privacy going forward. The other thing I would just mention at a high level is we're also going to be giving a lot of attention to safety considerations. I think, as all of us appreciate more and more, that the more that health IT systems and EHRs get embedded in the very fabric of almost everything that gets done in healthcare delivery. It's hard to think of going into a hospital, for example. It's hard to think of an activity that doesn't in some way either directly or perhaps indirectly implicate the electronic health record, the enterprise system that's there in place. I think that's there's greater and greater need for us to be able to have some way of being able to monitor and track safety issues, and a place for peers to be able to discuss safety concerns, safety things that have arisen, so that we as an industry can share those learnings and move forward. So we're going to give a lot of thought to how to be able to do that with industry input. I know there's a lot of industry interest in that as well. So we really look forward to diving into that more with industry. So I hope that gives you a good sort of perspective on the various things that that we're doing here at ONC and how we're thinking about that. I hope that leaves some time for questions. I really have enjoyed being here, and again want to thank you for the invitation.
Great, thank you for those remarks, Mickey. We do have a couple questions, so I'll just fire them over at you. One is, and I think maybe these two might be a little bit related, so I'm going to couple two questions together. One is ONC thinking through the privacy issues related to the use of vaccine certificates? And then perhaps a related question is around COVID passports and foundation for future similar passports for electronic documentation in the future. So new types of information related to COVID. How are you thinking about the privacy issues, but also documentation and other standardization?
Yeah, absolutely. Those are great questions. So as I said, I mean, we're really part of a multi-agency, sort of view on this. So it's certainly not an ONC thing or just an HHS thing. It really is, cuts across, many agencies as you think about, sort of the issue of vaccine credentials. One thing I'll say at the outset is I actually don't like referring to them as passports. Passports are something that are issued by governments. There is no right now, the passport is not, issued by the federal government, as being contemplated. So, I think of them as vaccine credentials or certificates. So there are a number of things that I think, as we think about that in general, are considerations that absolutely have to be a part of the ecosystem, however that unfolds. Privacy is a huge one. Security is a huge one. Protections against fraud is a huge one, and equally, important is health equity considerations. How do we make sure that whatever is available is accessible to everyone, so that no one is left behind or feeling like they can't participate in the return of their day-to-day activities, whether those social, leisure, or economic, because they don't have access to some type of certificate or credential. But as I said, we're really, this is just a part of a multi-agency view at the entire area, as we sort of think from a federal government perspective of what sort of the approach should be.
Great. We have another question that's related to the health equity issue that you raised just now and in past remarks. Does ONC plan to reinstitute the Office of Consumer eHealth as a way to achieve the patient access and health equity goals you highlighted?
Yeah, that's interesting. We haven't thought specifically about that, or at least it hasn't come to me. But I would definitely ask that question. I think it's a great question, and we'll certainly look into that.
Great. And then another question. In the COVID context, there's a lack of data standardization related to vaccine data across federal and state registries. What can ONC do to facilitate the standardization?
Yeah, I think it's a question that's, applies to public health at large, but what we've seen from, just from the COVID experience, and it's, somewhat related to the vaccine credentials, but when you look at our IIS infrastructure, the immunization information systems, that itself is a microcosm of the challenges that we have in public health data systems in general, which is you see, there's a lot of complexity in federal versus state versus jurisdictional. There are 64 immunization registries, for example. People may say, oh, wait a minute, there are only 50 states. It's like, well, there are other jurisdictions as well. And each one of those has their own authorities. And so when you think about any of this, each of them has their own standards. Sometimes in the same family of HL7V2, but with lots of variation. And each one has its own policies, and each one has its own user agreements. And that is sort of emblematic of, a lot of the issues that we have in public health in general. So, we don't have a magic wand to sort of say, here's how we're going to cut through all of that, except to, as I said, as a part of our consideration of the public health data systems, for example. I think that's an issue that we're going to see in almost every public health data system, that is a fact of the way that public health works today, and we need to sort of shine a spotlight in that and try to understand how we can make that work more effectively in the future.
Great. And we'll end on a big picture question. In the next 4 years, where do you expect the health IT world to be? Will there be revolutionary new EHRs, unprecedented patient control, and what revolutionary changes do you see on the horizon that we aren't even aware of yet? So look into your crystal ball and tell us, what the landscape's going to look like.
By definition, if we're not aware of it, I'm definitely not aware of it. So yeah, I don't know that I have a specific thing to offer, except the only thing that I would offer is, as we look across, sort of the internet economy, just look outside of healthcare for a second, and just think about, what sort of platform business models and platform approaches have offered. And they just offer the opportunity to think about things in different ways. And I think, if we can get anywhere over the next 4 years, to me, that should be our goal, is not, sort of a specific goal of we need a re-architected electronic health record system. I think that's for users in the market to decide what an electronic health record system ought to be in the future. But if we can move our way toward a platform type of approach where we have open sharing of data, the ability to have, sort of, both governance models and data exchange models and standards-based and non-standards-based exchange in a way that, that serves, that serves the industry at large and serves patients, then I think we'll have accomplished something, because we offer the opportunity then for innovation to happen in ways that deliver value and not be, sort of stifled or channeled in ways that are about any individual, or sort of narrow business interests. So to me, that's really, sort of the goal here, is to move us to that kind of platform economic and platform business model that we've seen in, in other parts of the internet economy that have served those parts of the economy very well.
Great. Well, thank you again for joining us. You certainly covered a lot of ground this morning, so we appreciate your participation and willingness to sort of tell us, how you see things and where you're going to be focusing, both in the short term and in the long term. So we really appreciate your work and the staff's work and everything that ONC is doing.
Enjoyed it. Thanks so much. Take care.
So we will transition now to our first panel, and I'm just going to bring up the panelists while I get going here. So bringing them all live. Looks like we have, let's see, do we have Dr. Georges? Dr. Georges, let's see, oh, he's having a problem with his video. Dr. Georges, maybe try logging out and logging back in, and I'll just introduce the panel, and then we'll see if that solves the problem. So this first panel is focused on data infrastructure and fostering emerging technology. The goal of this panel is to explore recent advances as well as ongoing challenges in healthcare data sharing and technology, using the COVID-19 vaccine administration effort as an example of our system's current opportunities and limitations. We will be joined today, I think, again, Dr. Georges is disconnecting and reconnecting. Our moderator for this panel is Sophia Tripoli, the Director of Healthcare Innovation at Families USA. And our panelists include Dr. Jem Georges, Chief Information Officer at He's back. Dr. Jim Georgis, Chief Information Officer at HCA Healthcare. Linda Hyde, coding terminologist with EMI Advisors in the Gravity Project. Jim Daniel, who is the lead for state and local public health at Amazon Web Services, a former longtime government official on public health IT issues. And then Joe Bastante, Chief Technology Officer at Blue Cross Blue Shield of North Carolina. So at this point, Sophia, I think I'll turn it over to you and take it away with the first panel.
Great. Thank you so much, Kristen. Good morning, everybody. Thank you so much for having us here. I'm just going to start with a couple of introductory remarks and then really just start firing questions at our very esteemed panel members. So, of course, no surprise to anyone here, the importance of data systems and infrastructure, data sharing, interoperability standards are really often overlooked in the health policy arena and by the public. It can sometimes be very difficult to draw the connections about why having a sophisticated and robust data system infrastructure with advanced data sharing capabilities and interoperability standards is so important to delivering high quality, affordable healthcare and improving people's health. The real-time exchange of health-related and healthcare data are essential to being able to equip healthcare providers and organizations with the information they need to better coordinate the care of our nation's families, ultimately improving their health, and to drive needed improvements in the quality and value of healthcare services throughout the healthcare system. We simply cannot achieve a high value healthcare system and improve the health of the American people and meet their health needs without these advanced capabilities. Of course, the COVID-19 pandemic has really been a pressure test on the existing capabilities of our health IT infrastructures, our ability to exchange data, and the use of technological innovations. And we've seen a number of substantial challenges, including efforts to administer COVID-19 vaccines and to track and do the follow-up at a population level that we need to do. But we've also seen quite a bit of incredible innovations and advancements in technology that are really reshaping how we think about healthcare delivery, and that will likely change forever consumers' expectation of the healthcare delivery system. The use of healthcare data and technology, of course, was prevalent in healthcare long before the pandemic. But over the past year, we have learned quite a bit about how data can be used for a range of different healthcare purposes. For example, we've learned quite a lot about existing challenges and innovations around targeting, testing, and vaccine distribution to at-risk individuals and to specific communities. And we've seen the rapid proliferation of virtual care and the ability to deliver care in other settings outside of healthcare facilities. So for the first question for the panelists is, how does where we are now with data and technology different from where we were before the pandemic? And I might just, unless someone wants to jump in right away, I might just start calling folks. Dr. Georgis, you look like you unmuted yourself. Why don't you go ahead first? Dr. Georgis, we might be on mute. A little bit of audio challenges, maybe. Okay, we'll go to, how about we'll bring in another panelist while we figure out.
Yeah,
I'm
happy to jump in. Yeah.
Thanks.
Sure. So I think, one of the things that's really different now with the pandemic and our data is just the huge volume of data that's coming in. We saw some major challenges with the volume of data coming in for lab reports, and now we're starting to see that challenge with immunization information systems as well. We're in the phase right now where not as many vaccinations are being given in phase 1, but as we move into phase 2, with the general public starting to receive vaccinations, the number of immunizations being sent to our state and jurisdictional immunization information systems is going to increase dramatically. And it's not just data being sent to those registries. Registries respond to queries from providers as well, so that they can actually provide information on previous vaccines received and forecasts for when second and third doses are supposed to be given. So that's going to be really important with COVID vaccinations, obviously, because people might be getting one of 3 different vaccines right now. As people go back for their second dose, they'll want to be verifying what the first dose is from that immunization registry. So we really need to make sure that our immunization information systems can handle that volume and they're not going to fail. So one of the things we're doing at AWS is really helping some of our state and jurisdictional customers think about how they can use cloud technology to just actually stabilize their immunization information systems so that they can respond to that huge demand that's going to be coming as we move into phase 2.
Can you hear us now? Can you hear me? Yeah. Ironically, she can't.
Dr. Deirdre, we can hear you, but now Sophia's having some audio problems. So why don't you go ahead?
It's not written in the stars. I think one of the main things we learned, and before and after I'll get to, is what we like to say is, we demonstrated during this pandemic that it can be done, but man, was it hard.
Great. Now we lost Dr. Deirdre again. I'm not sure what's going on. We lost Dr. Deirdre again, and we lost Sophia. So I think maybe at this point we should turn it over. Linda, why don't you tell us a little bit about social determinants of health and sort of what you've experienced? I know in your role on the Gravity Project, you were working certainly on sharing and collection of social determinants of health information before the pandemic, but be interested to hear sort of how the pandemic has either diminished or increased the need for information, sharing of that type of information.
Yes, thanks, Kristen. As Kristen said, the Gravity Project's been in place for about 2 years now. Our main focus is to identify what type of data is needed to identify and address people with social needs or social risk issues, and how do we identify the resources that are needed to address those issues. So I think most everybody is aware that the pandemic has actually increased the number of people who have needs in some of these social determinants area. We've seen it on television with the food lines for people who now need access to food, issues with housing, with the homeless populations. So what we've seen is not only was there already an increased emphasis on the impact of social determinants of health on clinical care and the need to address those to provide the right services and resources to people with those needs, but we've seen the population who need that information and help increase so much during the pandemic. And even after the public health emergency is over, there are going to be a lot more people who's still going to need that kind of support going through the whole recovery phase, not only from the healthcare perspective in terms of increased access to some of those services as it affects their clinical care, but just in the community at large, and what kind of community resources need to be available to help those people.
Great. And then Joe Bastante from Blue Cross Blue Shield of North Carolina. I would love to know, payers have been in a unique position during the pandemic because you have obviously very robust data and technology systems, but as was alluded to earlier, because the federal government is reimbursing for vaccines, it's been hard to find out who's being vaccinated because there's not necessarily a claims being submitted. So I guess I would ask, based on your experience of the things that have gone well, the things that have maybe gone poorly during the pandemic response, what do you think are the opportunities and challenges for data and tech going forward?
Yeah, that's a great question. And I will say that it felt very much like we were flying blind, like many people were at the beginning. I mean, certainly for the financial burden that we bear, is almost impossible to know what to expect. So that lack of data, the lack of experience played out really extremely in 2020. And, even up to the end of the year, it was almost impossible to predict the experience. It wasn't just for COVID itself, that's part of it. But I think as many of us know, there were the other medical needs and how people were no longer seeking care for chronic conditions and the consequences of that. So it's been very difficult without the data. I will say that, just being optimistic, I certainly feel like we're at a better place as a nation. Our reporting system, it seemed like going into the pandemic was lacking. I've been encouraged by so many organizations, both internationally and academically, and even within our own country, sharing data sets on genomics and other things. So I'm very encouraged. The only thing I would add, though, that I do still think about a lot is, and as much as the data standardization is really important, and when we absolutely have to make progress on it, I still feel like as an industry, we're very disjoint. Like if I think about from a payer perspective, right? We want to share data, for example, with our hospital systems, but each one sort of has its own way to make that happen, and a different preferred mechanism, maybe a partner that they work with. And the same for them, they're working with many payers, and some are saying, hey, you know what, we're gonna work with companies like Epic and require the technology to be used our basis for sharing. So the other point simply is that as we think about data sharing and making life better for all of the stakeholders, and especially for patients and members, I think that's probably the area that we need to focus the most to be able to really share information in a more fluid way.
Hey, can you guys hear me now?
We can hear you.
Hmm.
My apologies, folks, for some of the technical difficulties, but hopefully we're back up and running here. I want to ask another question for the panel. And forgive me if this question was just asked, please just let me know to keep moving if it has already been. But could you talk a little bit about what you've learned about the utility of healthcare data and technology because of the pandemic? Any insights you can share, any learnings?
Sure, this is Jim. I'll start. I won't be shy. I think, one of the things that we learned I wasn't expecting, I'm not sure how many of our public health agencies were expecting, was how important scheduling and call centers were going to be during the pandemic. I think we all kind of thought that, people are going to just go to their providers and get their immunizations and everything's going to work out great. And, we're in this situation now where people are frantically trying to schedule their appointments. And, it's this whole new set of data, this whole new infrastructure that we have to build that we've never thought about before in public health to, enable people to schedule their vaccination appointments across a variety of systems with a variety of different data systems. And we don't really have any standardization of that data to be able to share it across systems. So we see states when they're trying to create their scheduling websites, they just have to actually point to all of the different websites that can schedule. So you point out to the pharmacies, you point out to the provider, the hospitals, you point out to the public clinics. There's no real way to bring all of that data together into an integrated place for the general public to come and schedule a vaccination. It makes it really hard for the general public to schedule their vaccinations. And we've had to create new technologies around call centers, some scalable call centers. AWS has helped a lot of states create scalable call centers so that seniors and vulnerable populations can schedule their vaccinations. But as we move into phase 2, I think we really need to think big and start thinking about how we can use APIs and other technology to actually integrate all of the available vaccine appointments into a single place so that as the general public tries to schedule their vaccines, they're not having to go to 6 different systems to figure out if their appointment's available. We really need to start figuring out, how we can use technology to bring all of that together.
Thank you. Yes, please go ahead, Dr. Curtis.
Can you guys hear me now? I think I'm undouble muted. All right.
We can hear you.
Yeah, hey, a couple quick comments just from a provider perspective. With HCA, we're in 19 states, right? So what worked really well, what I'd say is what we learned in the pandemic was validating of what the future direction is for what ONC is trying to do in HHS. And what I mean by that is, if you look at the state of our data, a lot of effort was put in place to develop standards. Well, a lot of the stuff we had to measure and report out on were not part of plan standards. So there's a huge effort to map 190 hospitals, right, to a standard data set so reporting could happen. So that was a big lift. That validates the US CDI over time. If everyone had increasingly mapped data, oh my gosh, this would have been far less effort taking care of data and more taking care of patients. The second piece was then the how providers, I'm sure any entity has this issue. It seemed like in some instances where it was all of us reporting to one entity, Teletracker, So for the federal reporting, it was one entity that had technical expertise that we could all interact with. And then it was like a hot knife through butter, right? Then you pivot then to the vaccines where you had to interact with the public health departments. And it was in a way tough and in a way validating the future. With meaningful use, the only requirement was that you as a provider were making good faith efforts towards an interface, right? Not that you actually had one. So what we found is, we had 190 hospitals in 19 states trying to interact with a bunch of public health departments, that many of them, and they were trying to interact with all these provider groups, right? And each of those public health departments, we had some that didn't even have an interface yet because they hadn't yet gotten to it funding-wise, right? So either really investing in our public health departments in the data space so that for the next emergency, we're ready, or with the safer and saner, sort of the HIE, how can we use a TEPTA type model? So it's not 1,000 points to 1,000, many to many, but instead, like with teletracking, can we leverage an infrastructure that even if the data is standard, we're at least dealing with an HIE or a technical entity that really gets up every day doing it. It's one entity for all of us. And then they interact with the state public health departments, right? So I think there was an unnecessary complexity. And one last quick point, for example, we had to do spreadsheets, get on calls to figure out 19 public health departments, some of whom were at the contracting stage where we had to do all these contracts. Some of them were at the interface. And when we finally got to interfacing, well, you've seen one because you've got to do all the testing. One place, for example, if it's a blank field, it rejected the whole report. Other public health departments didn't. So I say all that and go into a little bit of detail to get people a flavor that the complexity and the lack of not just standards, but the model being more streamlined to decouple providers who have to deal with a variety of public health departments and vice versa would be, I think, validating of what TEP is trying to do and all the other efforts.
Thank you very much. I wonder, Joe, if you wanted to provide any comments from the payer perspective on this.
Yeah, thank you for that. Yeah, absolutely. As far as the utility of data, it's been such a stark reminder of how little important data we have relative to what we need. And the pandemic has really brought that forward. And be more specific about that. If you think about the role of a health insurer, certainly there's a financial protection part, but really, I would say at the heart of it, it's really health advocates to make sure that people are supported in this complex health ecosystem and to stay healthy. And if you think about now what we're facing with vaccinations, it's very important to all of us, I think, that people receive the appropriate vaccinations. But the thing is, we have so little data. And this gets to, of course, to the heart of social determinants data. Like, do people have transportation? Do they know where they need to go? Or do they have the skills necessary to make the appointments and follow up? Maybe it's a language issue. And so the one thing that's really been brought to the forefront about the need for data and utility data is the fact that we really have gone way too long without having the necessary data when situations like this happen to really help people and guide them through this. And, it's also, to me, a reminder, similar to, in spirit to what I said before. I don't think any one of us, for our organizations represented, have all the data and all the information. But I think if we put what we know together, we could really put the puzzle pieces together and support people much better. So I think there really was a great learning experience for all of us. I think it's a call to action as well.
Thank you, Joe. And I wonder, Linda, if I could turn to you and just with Joe's referencing of social determinants of health data, can you talk a little bit about any new data sources or sort of or renewed urgency for data types that might be emerging out of the pandemic from your perspective at the Gravity Project?
Yes, well, I think one of the areas that we realized is trying to make sure that we are identifying all the right key stakeholders. The Gravity community has over 1,000 members who actively participate in different areas depending on our domain that we're working on. But what we need to identify, and the pandemic has kind of raised and elevated it, as I said earlier, just from the sheer volume of people who are now in some of the situations where they need these types of services, is the fact that we can identify in a clinical care setting that there is some kind of social need or social risk. But for the most part, the services and resources needed to address that risk are outside the clinical care setting. They're based on social services, community resources, eligibility for different programs, and identifying where the gaps are in the kind of data we need to identify who needs and who's getting those types of services, and organizing that data in such a fashion that we can analyze it to look at where communities are doing well in addressing those needs, which communities may not be from an aggregated data sense. We can see where they may need additional help, where funding could work, how the payers can get involved in helping to help support some of these services, how providers can make sure that they're getting their patients identified by the right people to address those needs. And I think the pandemic has only increased the sense of urgency of being able to identify and get good data that we can all use to analyze what's working, what's not working, and how do we address the areas where there are gaps. There are gaps on both the data side in terms of how we standardize the terms and the concepts that we need to identify, and there are gaps on the interoperability side. And one of the key areas for interoperability is that when you're exchanging data between a clinical setting and a non-clinical setting, you now have different issues regarding privacy and security because many of those organizations are outside of HIPAA. How do you address that? How do you make sure that you're still identifying and securing the privacy of the individual and the security of providing that data and doing it in the way that will fit whatever model you need to support?
Thank you, Linda. I wonder if there are any reactions from the other panelists, and including thinking about, what are the most important next steps around data standardization and sharing across new and different data sets. Yeah, please go ahead, Dr. Traders.
Yeah, just to emphasize one more time, it's one thing to have data standards where the meaning of the data is established. It's another thing to operationalize that with thousands of point-to-point interfaces, because people interpret it differently. And there's a carrying cost for every single one of these: contracting, data use agreements, surveys, right? And so again, back to the notion of standardization, and this is not just about terminology, but it's about simplifying and reducing the many to many and creating more efficiencies in even how it's exchanged and some of the administrative paperwork and burden around it. I don't know how to get around it. Each state, had a core set of data that all of them wanted. And then Florida had like 110 other questions. And another state had, and that, it makes it, I think, challenging. It makes sense for a particular entity to want that, but it makes it incredibly challenging to actually execute as a society. So simplification of process, like TEFT is trying to do, not just data meaning standards, would be what I would say is an important next step.
Any other thoughts about sort of next steps? Yeah, please go ahead.
Yeah, I think, one of the things that we can do around all of the policy issues, because they're the toughest. Whenever I've worked on a project with immunizations, the policy issues are the ones that really, really slow things down. And I think looking at a model where we have consumer mediated exchange could really help. People are, going to be crossing state borders to get first and second immunizations, and you may have, your first immunization in one jurisdiction and your second in another. And we need to bring all of that data together. And there are policy restrictions that sometimes don't allow that sharing of data. But if we get the data into the hands of the consumer, then they could actually control that sharing. They could control the sharing with payers, employers, all the other people who want to have access to that data. And we have a couple of companies that we're working with, SDC and Docket, that have developed really interesting models to authenticate a person and allow them to have direct access to the data in an immunization registry in one of the IIS, and then potentially share it with other stakeholders that need that information. So I think it's a really interesting model for how to get around some of these issues. And going back to Jim's point about some of the challenges in connecting to multiple immunization registries, those projects for consumer access are both going through what's known as the Immunization Gateway, which is a project developed by CDC that really helps standardize the way you interface with all 64 IAS. So, you know, those companies are live in just a few states, but because of the way they've built it, it's easy for them to connect to any other jurisdictional IAS.
That's really great.
Bring
guys.
bring that future to today, please.
We are a little bit over, so I'm going to ask one last question and ask each of you or to just sort of give any thoughts on this question, as well as any final thoughts you want to offer for the session. As has been noted today several times, COVID-19 has really unveiled the harsh realities of existing disparities in health and healthcare in the U.S., where we've seen Black, Latinx, and Indigenous communities experiencing significantly higher rates of infection and death. One of the critical steps that's needed to really be able to center equity in healthcare delivery and payment is the ability to collect disaggregated data by race, ethnicity, primary language. We heard the director of ONC speak a little bit about this, as well as other socio-demographic factors. Any thoughts about what are the challenges from each of your perspectives? I think you guys all sit in really interesting different sectors where you're facing sort of a different set, and maybe potentially some similar sets of issues. What are the challenges you're facing in being able to collect and report on this data? Any opportunities that you see in really being able to move the needle forward on collecting and reporting on disaggregated data moving forward?
You know, I'll start us off, and I'll keep it really brief, knowing we're over time. The thing my final thought on this topic would be, it ties into what Dr. Georges was talking about. You know, we focused a little, for example, on vaccine data and vaccine related information. But if you broaden this to everything, right, we now are collecting data, post-market data on vaccine efficacy. You know, we're talking about race, ethnicity, and language. We're talking about social determinants. Every one of these in this complex network of these thousands of people that need to interact is really problematic. So I realize it's a big challenge, but I really think we have to find a way, from my view, just my view from a government perspective, but if possible, even an industry perspective, to find a simplified, unified way of doing this, because I think it's a near impossible burden if we can't, as Dr. Georges was saying, if we can't find a way to work together and simplify this ecosystem.
Thank you, Joe.
I'll just add that I think immunization information systems are one of the keys to making this happen. And one of the things that we need to do as a country is bring together all of our immunization information systems in a collaborative process, talk about the lessons learned, and really think about what a modern IAS looks like, and think about what those standards are that support it, and have everyone come to agreement, so that we don't face all of the challenges that we were facing during COVID-19 response for this. We've got to be ready going forward. And as I know it's tough to do right now in the middle of a pandemic, but as soon as we have breathing room, we've got to bring those stakeholders together and do that homework, so that we can actually build the systems that are going to work in the future.
And
I'd make one.
oh, go ahead. Go ahead.
I was just going to say something brief. In the spirit of let no good crisis go to waste for good cause, I hope that as things calm down, the energy behind and the urgency with which we address some of these issues isn't diluted.
Thank you. Linda, go ahead, please.
I was just going to say that I think one of the strengths of the Gravity Project is that we are building a consensus group that covers the gamut of all different stakeholders in this area. And one of our goals is to identify what's the minimum data, what do we need as a data set that we can standardize, not trying to encompass everything that's available out there, but what can we achieve a consensus on that in this particular domain for social determinants, for food or social isolation or transportation, what are the key factors that we need, and how do we educate people as to why they're needed and how we need to use them? So I think if we can continue to have that kind of consensus where we bring people together and say, what can we make work and how do we make it work, that we can build the kinds of systems that we've been talking about here that make it easier to share and safer to share data and to share information and learn from that information.
Yeah. Hey, Linda, if I could just say real quickly, thank you for that. I think that's a really important comment. And I would also say we don't need to solve everything to solve anything. And this is a great, what you're working on is a great place to focus.
Thank you.
Well, thank you very much. We're a little bit over time, so my apologies to Kristen and the team, but really interesting conversation. Thank you all very much for joining this panel, and I'm going to turn it back over to Kristen to take us into the next session.
Thanks, Sophia. We will just do a bit of a transition here as our first panel goes off camera and our second panel comes on camera. Our second panel, which is joining now, will be focused on patient access and trust. This panel is going to highlight the importance of and challenges inherent to patient access to health information. So this is something that we have talked about all day when it comes to, even the remarks from Justine Handelman to start the day, to Senator Cassidy, to the first panel. We've heard about the importance of consumer access and the important role of the consumer and some of the tensions that are inherent there when you think about things like privacy and security, new types of data, and new types of technology through which patients are accessing and using their health information. So since we are over time, without further ado, I will turn it over to our moderator for this panel, Lena Walker, who is Vice President of Health Security at AARP.
Great, thanks so much, Kristen. And I'll start by responding to a question or sharing a perspective from a question from your audience to Mickey about looking into the crystal ball. A couple of years ago, we brought together a futurist to talk about the future of digital health to a group of patient and consumer advocates. And what struck me and what stayed with me from that conversation was one of the participants ended up saying that maybe in the future, consumers won't be spending their time thinking about how to choose the right health plan. They'll be spending their time thinking about how to choose the right smart refrigerator. And underlying that was the concept that by bringing data from all these different sources that's customized to the conditions, medical conditions, health conditions of the individual, their family, their lifestyles, their family history, that this technology could provide recommendations for healthy foods that could allow them to live a healthier life. And so I guess that's the promise of bringing together all these, disparate forms of data and the use of technology platform. But as we know, it's a long way to get from where we are today to that future state and the promise of that future state. And that's exactly what this panel will be discussing today. Like, what are some of the patient issues? What are trust issues? What are access, privacy, and security issues from the perspective of the patient? And our panelists today will be talking about their experiences in what works and the challenges that they've experienced, challenges that they've seen with patient data sharing. Coming from a consumer advocate organization, I can share that yes, we want to make sure that patients have access to the data, and to Linda's point, Linda from the Gravities Project point, bringing together data to enable better care, but let's not at the expense of privacy protection. So let's make sure that we build the privacy and the security protections to enable that. And yes, data and digital tools can be helpful for consumers and families to better manage their health, but we should not expect that the health system writ large should abdicate from the responsibility of making sure that the information flows to the right clinicians and the right health plan in the right setting. And yes, consumers and families like the option of virtual care, as we've seen in this pandemic, but it should not just be made available to those who happen to live in the right zip code, right? We've talked about the equity issues in the last panel. And finally, before we get to our panelists, I'd say, yes, consumers and their families want to know and understand how their data are being used and who's using it. So let's not make it difficult for them. Let's make it easier to understand. Let's allow them to prevent and allow them to amend. So with that, I'm going to turn over to my panelists. In the interest of time, I'm not going to read the details of their bio. That should be available in the program information. But I'll share some highlights of our esteemed panel. Dr. Darylyn Moya is the EVP and CEO of the American College of Physicians. Dr. Moya's research and scholarly activities have been in the areas of diversity, equity, and inclusion in healthcare, medical education, high-value care, patient safety, to name a few. Dr. Mark McNeil practices family medicine in Asheville, North Carolina, and his interests include geriatrics and health information technology. Leanne Eagle is the executive director of the Living Well Center for Excellence, Project Living. She's also director of the Health and Wellness Program at MAC Inc., which is an area agency on aging that serves the four lower Eastern Shore counties. And last but not least, we have Laurent Roteval, who is SVP of Strategic Technology Solutions and the Chief Information Officer at Cambia Health Solutions, where he leads the development of next generation technology solutions to create a more patient-focused, person-focused approach to healthcare. So thank you all for being here today. And we will start with a lightning round before we get to questions. If each of you could share just a few minutes, 1 or 2 minutes, your perspective and experience and what has worked and what hasn't worked with patient information sharing. Let's start with you, Darylyn, and then we go to Mark, Leanne, and Laurent.
Thank you so much for inviting me, and I really enjoyed the last panel. So much resonated. I'm an internist and infectious diseases physician, and I practice in an underserved area of Philadelphia where my patients' longevity is 20 years less than their compared folks in Center City, Philadelphia. You know, the ACP has strong policy around privacy protections for patients, and strong policy around digital tools and health IT that is patient-centered and focused in a way that it's communicated, coordinated, and comprehensive and integrated into the ongoing care, face-to-face care with our patients and putting our patients front and center. And the pandemic really brought to light and exacerbated existing inequities. Many patients with a 4th grade reading level don't have much digital health literacy, let alone access to broadband. We saw that many of our patients wanted to do telephone only audio calls for a variety of reasons. Some of them don't have smartphones. Some of them don't have cell phones at all. They're still landline locked. And many of them had privacy concerns by doing calls on a video in their own home for their computer. So we really need to look at this as integrating intelligent augmentation into existing care, not to supplant care. It's a tool in the digital toolbox that we have. And when you've seen one practice, you've seen one practice. When you've seen one patient, you've seen one patient. So figuring out how we can have a better, more comprehensively integrated system that feeds into public health databases and does it in a central way that doesn't leave many people behind is critical. And the last thing I want to say is that, you know, the explosion of cell phone apps has been interesting, and we really need strong privacy protections around that. Lots of patients came to us with concerns, for example, about the contact tracing apps for COVID-19 and their privacy concerns. So with that, I'd like to thank you again for inviting me. I look forward to the discussion.
I guess I'll jump in at this point. Again, my name is Mark McNeil. I'm a family physician in solo practice in Asheville, North Carolina. The name of my practice is Trinity Family Medicine. Thanks again for letting me be part of this. It's been a pleasure so far. I love my job. I've got highly satisfied patients. 85% of my patients use my portal or my app as their primary means of communication with me. It's that heavy use that allowed me to make those positive statements to you at first. My patients have high trust in my portal and my apps. And this is how I've run my practice from day one when I started 8 years ago. In reference to Lena's question earlier about, you know, what has worked and what has not when it comes to patient privacy and success with sharing tech information with patients. I'm really, I think we make no mistake. I value the privacy of my patient's data, and I work hard to maintain that. But sort of level setting from a patient perspective, and when it comes to the success of my office, it was valuing the patient relationship and access that allowed me to have success with this technology, but also to get patients to trust it. Patients, you think about your patients using all the other technology while they're buying things online and getting their dinner from Uber Eats and making the reservations on OpenTable, they use it because it works and it's a good experience, not because they are so confident in the privacy. So, I found when it comes to success, it was making sure my patients were well trained and making sure giving them good service. So I think I like to help offices move forward with that and help them do better with those concepts. But I just think we need to keep those concepts in mind as we move forward into the digital age, as while we're talking about keeping privacy, high standards of privacy. Leanne, I think you're muted.
My name is Leanne Eagle. I am the executive director of the Maryland Living Well Center of Excellence, and we actually have worked very hard to marry that, the clinical side to that community side. We've been using our health information exchange. We also worked with the EagleForce platform to actually have the clients being able to log on to the MiniRx and be able to see their data. The HIE has been extremely critical here in Maryland. They have allowed us to actually become that community side where we actually can get referrals from that on the clinical side. So they get the verbal okay from the client, then we can see what we need. So we are also, that way we can bi-directionally data share, which is very critical. In this whole picture, you've got to have the government piece. We have the State Department on Aging has been extremely cooperative here in Maryland. They are a big mother agency. We have the State Department of Health. We have the the Center of Excellence. We have the Maryland Primary Care, and we also have 30 some hospital partners in Maryland. So when you start to put that big picture together, you can really get that data sharing going from the clinic, from the state to the clinical side to that client side, and the client, which makes it very client focused. And that's been part of our strategies from the very beginning. And it is happening for us, which we're very lucky in Maryland, because Maryland is very unique. So thank you. I look forward to sharing with you.
Thank you. And Laurent?
Thank you, Lena, and great to be part of this event today. I really enjoyed the presentations. Laurent Rodeval, based in Seattle, leading technology for Cambia Health Solutions and the Blue Cross Blue Shield Regions Health Plans in the Pacific Northwest. I was thinking about Miki Tripati's comments earlier today, talking about how do we get organizations to adopt the new standards and the new rules, prior to waiting for the last minute, and strictly doing them from a compliance standpoint. And Lena, you mentioned in your introductory comments about the need to be, patient-centric, and what I interpreted as, really meeting not just the member, the patient, the employee, but the person where they're at the point where they're at in their lives. And being a healthcare consumer is not a powerful position, right? It tends to be a very vulnerable one. And what I have seen to be very effective for us is, one, the rules and the standards are actually not that difficult to adopt. We have found that we have been able to get ahead of the curve. We've been able to implement them with relatively low cost. And in particular, in our backyard, working with organizations like OHSU in Portland, Oregon, or MultiCare in Tacoma, Washington, we've been able to demonstrate some great examples with prescription med reconciliation or prior authorizations that are major pain points for individuals, how we can make it easier by leveraging the standards and the open data liquidity while doing so in a private, trusted way. What we believe really works and is important, though, is not to start with technology, not to overwhelm necessarily with the standards or the open APIs, despite people like me loving to talk about it, but it's really to start with the sort of a human-centered approach, an empathetic approach to the individual, and really understanding what are the situations these people are faced with, and how do we design tools and solutions that are not point solutions, but fully intuitive, mobile, seamless experiences, right, for individuals that again present themselves in a relatively frictionless way at the point of where they are, that are convenient, and allow them to have access to the best doctors, and to create sort of virtual interactions, again, that are protected with their physicians, and also don't present the financial risks, right, that we read about, unfortunately, far too often in the press. So for me, it's all about the end-to-end experience and making sure that we leverage the standards and we leverage the technologies that are available to us, particularly as we learn from retail, and making sure that we build solutions that support a person's experience from an end-to-end standpoint.
Great, thank you. I want to pick up on the notion of trust that both you, Laurent, and Mark, Dr. McNeil, you raised in your comments, and tie that into what you were saying, Dr. Moyer, about how different communities have different levels of trust, and you don't want to leave communities and people behind. So how, as we roll out these new standards, as we roll out, like different portals and reliance on data and the consumer's ability to navigate in this new environment, how do we make sure that we don't leave people behind? How do we address the differences in trust from different communities, people with different experience, backgrounds, history, and access?
Well, I think you've got to really, think globally, but act locally. The patient's experience is the patient's experience. And we need to recognize that, every survey that's looked at who patients trust, it's come down to typically their primary care practitioner, the person that they have a longitudinal relationship with, that face-to-face human touch. And I really do think we need to make sure we are engaging the frontline facing clinicians and all of our patients when we sort of make decisions about this. I think about how different it would have been if we had had a centralized, interconnected system for COVID vaccine access. That did appreciate the fact that many of our patients don't have computer or smartphone access, because what we got out of it was a deluge of calls to physicians' offices and other practitioners' offices, not just about, I'm worried about this vaccine because of their previous inequitable experiences in our healthcare system, but I have no idea how to navigate this vaccine Hunger Games that's going on. So we really need to engage the folks on the front line, and that are the patients and the front-facing clinicians.
But I believe, yes, the PPC, the primary care physician, is very critical, but it's also bringing in those community organizations that, because when you look at a graph, a pie chart, and you look at the amount of time that a PCP is in front of that client, it's very small, right? The amount of time that they are embraced with a community-based organization is much bigger. So if you can gain the trust between the PCP and that on a community side and marry them together, and then you are getting that information back to the PCP through a platform or through a health information exchange, then that's when these changes are going to be able to happen.
Great. So I actually want to raise something that came up in some of our conversations in the past with some advocates. And it's that there is this aspect of trust, the patient level of trust, but there's also the issue of the clinician who would be interacting with the patient and their trust of the system itself. Now, can you provide maybe some commentary on what do you think are considerations for clinicians or providers of plans when patients are asking to share that data with third parties? Mark, do you have some thoughts there?
You know, I may just piggyback a little bit on some things that Dr. Moyer said and Leanne Eagle said. You know, when it comes to, you know, patients' trust in this technology and where the information is shared, the person they're going to be looking to most is their primary care physician. The second thing they're going to be judging is their experience with the technology. And those are highly related. I mean, right now, how many of you can pick up your smartphone right now and get a same-day appointment with your doctor? Okay, not many people. All right, you may be able to get an appointment with a doctor somewhere in an urgent care clinic or maybe a telehealth service that doesn't know you. But the technology is there for patients to be able to do that. And when my patients are able to do that, it greatly enhances their trust in the technology. It greatly enhances their trust in me. It's good for the relationship. And I think making sure patients trust that the transfer is important, that transfer is important. I just don't want us to right now, I imagine I've been doing this for 8.5 years using this low overhead portal-based approach. And I can count on one hand how many times I've been asked by patients about the privacy and transfer of data. The issues that come up more are the usability and their access to me. So if we're worried about patient trust, I think we need to be having soft incentives for offices to make sure that the technology they implement is implemented well, that they train patients well, that they're able to improve access. And as we implement standards and regulations, we need to keep that in mind, that it's not making it harder for patients to use the technology or make it harder for providers to actually provide it. That would be my thoughts there.
Great, thank you so much. Now, we are over time. Kristen, should I wrap up?
You can keep going. You can keep going. Representative Peters is still voting, so we have some extra time.
Okay, great.
I'm here. I'm back.
He's here, so.
All right, I think we need to wrap up in that case.
Let me wrap up and let me thank our panelists for a terrific discussion. Thank you.
Thank you.
Thanks, everyone. While our panel is transitioning off, I will go ahead and introduce our next speaker, Representative Peters. And Congressman Scott Peters serves California's 52nd Congressional District, which includes the cities of Coronado, Poway, hopefully I'm saying that right, and most of northern San Diego. First elected in 2012, he currently serves on the House Small Business Committee and the House Energy and Commerce Committee, where he advocates for investment in scientific research, supports the military's goals to enhance their energy security, and fights for common sense healthcare reforms that work for families and small business owners. Scott Peters is a civic leader who has made improving the quality of life in San Diego his life's work. As a member of Congress, Scott's emphasis has been on promoting and expanding San Diego's innovation ecosystem, advocating for San Diego's pivotal role as a partner in the national defense, and making government work again. Ranked the 4th most independent Democrat in Congress by the National Journal, Scott Peters understands that business problems have bipartisan solutions and is never afraid to work across party lines to build consensus and get things done, something that is definitely needed in healthcare and technology. So thank you again for joining us, and I'll turn it over to you.
Thanks, Kristen. Sorry about we're having to run back and forth and vote. And because of COVID, we have to vote once, come back for 40 minutes, vote again. So I appreciate your indulging me. As you said, I represent California's 52nd district, where life sciences is a big part of our economy, and on the Energy and Commerce Committee, where members have been debating the best way to strengthen this country's health IT infrastructure for many, many years. In 2009, before I was here, there was the HITECH Act, which did succeed in driving up the adoption of electronic health records, but fell short of expectations in many ways. While I was in Congress, but not yet on the committee, we did the 21st Century Cures Act. That set in motion rules and regulations we're just starting to see roll out. And the CARES Act, which we passed last year, will make large-scale investments in the modernization of our national public health data infrastructure. But COVID-19 has exposed some weaknesses in our public health surveillance system and the data infrastructure that supports it. We have inconsistent data collection and reporting requirements. That's slowed our response to detect and track the size and scope of the pandemic during the early days of the outbreak. Among the many practical effects of these data gaps, we have missing data on race. It's masked the disproportionate effect on communities of color in the early months, in particular of COVID-19. It made it really hard for us to assess it and react to it. So in part, the gaps persist because health IT and the regulatory challenges make it difficult to rapidly assemble data from all the various data sources and systems like public health departments, labs, clinics, and hospitals. The systems aren't always compatible because data collection and reporting are not standardized across these reporting entities. Compare us to a place where, like England, which has a national health system, they don't have these inconsistencies, but for better or worse, ours is more atomized. And so I guess it's not surprising that these kinds of gaps and inconsistencies exist. So data modernization efforts are underway at the CDC, but the real problem often starts prior to reporting. So take a look at mortality reporting. That's a good case study. There's a lag in reporting mortality data, but the death records often are missing important details like the underlying health conditions and information about previous hospitalization. So in addition to the challenges associated with reporting and collection between the federal and state governments, there's also data silos. So you have collection issues, and you also have these silos where the federal government, within the federal government, agencies aren't linking existing data for decision-making and evidence-based policymaking. So there's over 2,000 government health data sets at the federal, state, and local levels. Many of these data sources are siloed, and so the answers to the most basic research questions about COVID remain unknown, like what's the true fatality rate from COVID-19 infections? Does adequate access to lab testing correlate to avoided hospitalization and mortality? How do COVID-19 outcomes like hospitalization, the likelihood of being put on a ventilator, the risk of mortality vary by race and gender, and even by geography? So I introduced the Bipartisan Health Statistics Act with my colleagues Brian Fitzpatrick, Anna Eshoo, and Lucy McBath, for the simple reason that without access to timely and accurate data from local, state, and federal levels of government, researchers and policymakers can't answer the crucial questions we need to reopen the economy and prepare for the next crisis. Crisis often shapes our priorities in DC, so we should use this one to streamline ad hoc data sharing agreements between local health departments, states, and federal governments. We should remove data silos across the multiple federal agencies, and we should fix the patchwork of data systems responsible for recording and reporting vital statistics. Most important, the American people should have confidence that their data is also protected, especially in the middle of a pandemic. So it's more important than ever that government is transparent about how health data from states, federal agencies, and across HHS units are used, how it provides secure access to researchers, the rules governing interagency data sharing protocols, and making data available to the public and to researchers while still protecting privacy. So we've got a great response from the statistics community in and around DC. And we're happy to share any more thoughts about it. We're hoping to get the bill passed in this term. Much of it can be implemented by a friendly Biden administration if they want, but part of our bill that provides grants for state and locals to up their game would need to come through Congress. So we're looking forward to working on it, and we think it's pretty promising. Anyway, I appreciate your having me, and if you have any questions, I'd be happy to try to address them.
Great, thank you, Congressman Peters. I guess I would start, and you touched on this a little bit, but what do you think are the biggest data sharing gaps that have been exposed by the pandemic? Obviously, we, I think a lot more attention maybe than happened previously has been paid to our public health system. And I know you guys have some ideas as part of the Statistics Act. So what do you think are the biggest gaps?
Well, incomplete demographic information. So states report proportions of total cases and deaths, but among different racial groups and ethnic groups, but don't report other factors like access to testing, hospitalization rates. So we're not seeing the whole picture. And in the early days, a third of states were not reporting data on outbreaks in congregate facilities, like not just nursing homes, but homeless shelters, correctional facilities, and that sort of thing too. So in November of 2020, Tom Friedman's organization did a report on state level data sharing, and we ought to revisit that to see if improvements have been made. But basically, the data reporting is not standardized across states, and you've still got all these different federal agencies kind of touching the data without a lot of coordination. So it's a lot of work that has to be addressed.
So, I think the problem that you've described seems pretty big, right? There's a lot of things that we need to do to improve the current state. So what would you recommend as a first step, as a starting point to sort of get us off the ground? And would you recommend that first step take place during the pandemic, or should we wait till the pandemic is over? Sort of how should we think about something incremental that could be done perhaps in the near term?
Well, I don't think we have to wait for the pandemic to subside for folks to talk about this. We're all on Zoom anyway. And the fundamental problem is we don't have a national public health data strategy. So our bill doesn't answer it, but it establishes a council comprised of all the relevant HHS units like CDC, ONC of Health Technology, NIST, VA, Indian Health Service. We combine that with professionals from the public and private sectors, academia, nonprofits. So we need to come up with strategy and then implement it. And I think, it's, the first thing you need to do is recognize your problem. And that's what we've done. We want to now characterize it and figure out what's the better way to handle it. And that can happen right now and should.
Great. Okay, and maybe the last question. So over the past few weeks, Congress has debated and taken action on the American Rescue Plan. So where do you think we go from here as far as opportunities to move additional legislation like the Statistics Act? And what do you sort of see as the opportunity for healthcare legislation going forward?
Well, I hope it calms down a little bit. To be honest with you, personally, I'm a little bit disappointed that we didn't start with a big bipartisan bill. We did 5 bipartisan COVID bills last year. But there are a lot of objectives in getting this done. And I think some of them had to do with the president keeping his campaign promises. So I'm happy to support that. I'm really happy that Joe Biden is president and rooting for a successful administration. But now's the time to sort of go back to our committees and plow through this stuff and think about it. So I think, now's the time to work it. And one of the first things we've learned from this pandemic is about these data gaps, and it should be a completely bipartisan effort. It already is a bipartisan effort. So we're going to reach out to the Senate and see what we can do to find some folks who can help us elevate this. We'll work with the administration to get them thinking about it. And then, we got to reach out to the states and locals to make sure that they're on board as well. So, I think it should be a calmer time. And I think that the administration will turn toward bipartisan initiatives, and this can certainly be one.
Great. Well, thank you again for taking time out of your schedule to join us. We really appreciate your perspective and the thinking that you've done, particularly on the modernization of the public health IT infrastructure and all of the associated opportunities and challenges that we've seen over the past year or so. So thank you for joining us. And we look forward to hearing more from you on the Statistics Act and other healthcare issues.
My pleasure, Kristen. If you have ideas for us, always let us know. And thanks for the good work you're doing.
Great, thank you.
Take care.
So at this time, we are going to transition to our final speaker. Let's again hope the technology works. Let me see here. Our final speaker is Cincy Hernandez Cancio, and hopefully I am pronouncing that correctly. Forgive me if I'm not. And let me pull up her bio here so I can give her a proper introduction. And I'm also going to, I think, Cincy, you wanted me to share my screen to advance the slides, and you'll just let me know. Okay. Let me do that just after I introduce you. So Cincy Hernandez Cancio is Vice President at the National Partnership for Women and Families, where she leads the Health Justice team. She is a national health and healthcare equity policy and advocacy thought leader with 25 years of experience advancing equal opportunity for women and families of color, and almost 20 years advocating for increased healthcare access and improved quality of care for underserved communities. Cincy is deeply committed to transforming our healthcare system to meet the needs of our rapidly evolving nation so we can all thrive together. She believes that our future prosperity depends on ensuring our healthcare system routinely provides excellent, comprehensive, culturally centered, and affordable care for every single person, family, and community, and that this requires the dismantling of structural inequities, including racism, sexism, ableism, homophobia, transphobia, xenophobia, and religious bigotry. Cincy has a number of other incredible credentials in her background and experience, so her bio is available on our website. And in the interest of time, I think, Cincy, I will just go ahead and turn it over to you, and I will go ahead and get my screen shared here.
Excellent. Good morning, everybody. Buenos dias. It is so good to be here, and I really appreciate the invitation. Today, I want to talk about how everything you heard this morning impacts health equity. Can we share the screen? Okay, I'm not, there we go. Excellent, excellent. So, sorry. I apologize, but I just lost from my screen my notes, but here we go. Okay, COVID-19, as people have already discussed, has accelerated the digital health revolution. Not only do we now have Operation Warp Speed, we have light year increases in the use of digital technologies. CMS reports that the increase in telehealth usage between mid-March through early July, telehealth services went from 14,000 to over 10 million. We've also seen telehealth being used, digital health being used for digital contact tracing, and the many other ways that individuals, families, and communities are using distant technology as a way to cope with the digital pandemic. That includes the distance health, that includes distance learning, that includes distance living in general. And so that begs a question. Next slide, please. Will tech save us? Next slide. Or not? And despite the fact that we are talking about computers, the answer is definitely not binary. It depends. Next. The reason is that technology is not neutral. As Senator Cassidy mentioned earlier this morning, there is a whole vista of possibilities. We are right now at a critical inflection point, and one road holds promise with all of the cute and helpful droids, but the other direction can lead at least some communities down a path of the horrors of HAL and Skynet. From a health equity perspective, while there is incredible opportunity to advance health justice, if we are not smart and intentional in understanding both the limits of technology and the inherent inequity that technology reinforces, things could be made worse for precisely those communities that are closest to the pain and are consistently left behind. We need to have a foundational conversation about system transformation. How we deal with technology will directly translate into accelerating or hindering the path to health equity. And so we need to look at all of this from an equity lens, as Mickey Chaprathi said earlier, we need to approach health equity by design. Next. We need to understand, to begin with, the difference between equity and equality. Some people, you've probably seen some version of these kinds of illustrations before. We can't just provide the same thing for everyone and expect it to work. What we provide must be tailored to the underlying structural inequities that people face, as well as individual level barriers. With apologies to little fires everywhere, we need to understand the difference between making good choices and having good choices. And this is, we see this in the digital health space in 3 core areas. There's bias in tech, the digital divide, and one of the overarching themes of our whole conversation today, which is trust. Next, please. So let's start with bias technology. I highly recommend folks get a hold of the new Jim Code by Rua Benjamin, because it really lays out how bias technology actually is. There's some of the obvious things that are related to skin color that have been making the news lately, such as pulse ox machines that don't work very well depending on your skin color. Similarly, automatic hand washers and the automatic faucets and automatic soap dispensers. They all have challenges, like in recognizing that a human being is standing in front of you trying to get the service that you're trying to get, if that human being happens to have darker skin. And let's not even talk about the challenges with facial recognition software. And so in a world of algorithms, we also have to understand how underlying data will skew your results. Senator Cassidy talked about AI and the decision support and doctors' ability to override their prompts. But we also have to understand that there are real reasons that are not just special exceptional circumstances why some of these prompts need to be overridden, because our evidence base is very biased. Plenty of data around that. Most of our evidence base when it comes to healthcare was built upon the experiences of white men. So the fact that the evidence base is biased means that the training data for AIs is biased. So that means that the decision support is biased. And we've seen, many recent reporting around specific algorithms and decision support that's been used in the healthcare world that actually directed more resources to less sick white people as opposed to and ignored the needs of equally sick Black people. So this is especially important when you have doctors that don't have the information about the biases in the evidence base, and also when we have payment systems that require fail first strategies, because there may be reasons why it would actually risk someone's life and health to wait for them to fail first, especially if they are being treated based on evidence that doesn't necessarily apply equally to them. Next, the second core issue is the digital divide. And this has been a hugely spotlighted as a major pain point during the pandemic. We have seen what happens with the digital divide when it comes to work, when it comes to schooling, when it comes to health, and as some people already referenced, for signing up for a vaccine. Next, this slide illustrates the importance of what we measure, right? If we look at the FCC's data on broadband availability, it says that roughly 25 million people don't have broadband access, and that's roughly 7 to 8% of the US population. But when we look at Microsoft's data on the actual use of broadband, it ends up being almost half of our population that isn't using broadband. And we need to understand the why behind that, right? Think about what that means in terms of who might actually benefit from digital health. It's not just that there's broadband, but questions about, is the broadband affordable? Is the broadband actually available to every member of the family, especially when you have, like in my family, 2 grown-ups working remotely and 1 kid working remotely for school, and our broadband, and we're in a very, a area with a lot of good broadband, craps out on us constantly. Imagine if you're one of the regions where broadband is less available. And then there are issues about what hardware does a family have or the individual have to be able to access broadband, and how confident are they in using it, using digital means for communication about such private information like their health. Next slide. So what does this mean in terms of HIT? We have to look at both the participation and the quality of use. And so those questions are things like, your doctor makes a patient portal available, but what can you actually do with it? Can you schedule appointments? Can you send email in a secure way? Can you share your own data with others that you feel you want to share your data with? Can I actually correct or add information? This is really relevant in terms of vaccinations. A lot of people don't get vaccines at their primary care doctors. Like I get my flu shot every year at Giant because it's there first. And I have no way of correcting the information in my health record saying that I actually have my flu shot. It keeps prompting me to please schedule your flu shot. Some providers also, we heard earlier, have their own data apps. So first of all, what are they doing with your data? And does that mean that you need to have 10 different apps or keep track of 10 different portals because you are going to different medical providers, in different systems? The fundamental health equity question is, knowing that roughly half of the nation doesn't access broadband, how do we guard against creating a two-tiered system? Telehealth needs to be a meaningful choice for everyone, but it also cannot become a requirement or the only way a person can access healthcare that is high quality, culturally centered, language accessible. Next. The third big issue is trust, and that permeates everything. It's important to take a step back for a moment and look at the whole ecosystem. Consumers may not be aware of all of these intricacies, but they do understand the large contours of how far-reaching health data is. And they expect privacy and non-discrimination protections for all of that health data, not only the data that's above the HIPAA-protected waterline. Surveys show that people are shocked to learn that as soon as their health data is downloaded on their phone, HIPAA protections don't apply. And it is, as was said earlier, the Wild West. Building and enforcing these privacy guardrails for all types of health data is foundational to fostering an environment of trust. Next. So what does this mean? What does trust mean, especially in times of such deep racial inequities? We hear a lot, healthcare systems complaining, why is it that patients don't trust us? At the same time, the medical establishment doesn't trust patients. We need to apply the platinum rule, not the golden rule that we heard earlier, which is do unto others as you want done to yourself. Because yourself, what you want done to yourself is very much grounded in where you are in terms of power, privilege, and resources and risk, right? What we need to do is a platinum rule, which is to ask them what they need and want and do it. Though we have been seeing a willful blindness to the history of abuse that a lot of communities have experienced. And often the practices of the current healthcare system, especially in not trusting people and not acting in a trustworthy way, is very much coloring and determining very rational decisions about who to trust and how and with what information. We act like we can logic our way out of this, that if patients and families just understood the promise of better data capture and exchange, that everything would be, they'd understand the benefits, they'd understand how much better their care would be, and all these trust issues would be resolved. But we need to reject that assumption. People do understand the promise, perhaps not at the technical expert level of this audience right now, but at an intuitive level based on living through the technical revolution. The lack of trust is not due to insufficient understanding or technical expertise or sophistication. It's a rational response to generations of lived experience among peoples and communities that have experienced, for example, unethical experimentation, poor access to care, mistreatment in the hands of their providers, implicit as well as explicit bias in the healthcare system. And it ranges everything from, just to name a few examples, forced sterilization, medical abuse and experimentation without informed consent, such as contraceptive testing on Puerto Rican women, how misused Henrietta Lacks was, how Black, Indigenous, and other women of color, as well as women with disabilities, have been disproportionately subject to forced sterilization. And that remains to this day, as exemplified by 2020 accounts of forced sterilization in US immigration detention. So next slide, please. Discrimination in healthcare is our foundational reality. And this is information from a really groundbreaking survey that was done by the Harvard School of Public Health, NPR, and the Robert Wood Johnson Foundation, where for the first time, people were asked a host of different questions about their own experiences with racial discrimination. And two of those questions were specifically about healthcare. And, for those of us that have been working in health equity for years, we're not that surprised about how rampant healthcare discrimination is, and how people are making decisions about whether getting care they need is worth subjecting themselves to the very real harm of being treated with racism. And there's plenty of evidence about how that is a very real harm that is toxic and affects people's health, not just psychologically, but physiologically and all the way into their changes into their DNA. And this, let me just remind you, this is, I think, 2018 data, if I'm not mistaken. This was before COVID, before last year's reckoning on racist injustices. So we can only imagine that all of these rates have increased significantly over the last couple of years. Next. So what is it that people want, and how do we give it to them? How do we move forward? Well, the thing is that we want it all. We want access and we want privacy, and we shouldn't have to choose. We want access in terms of increased sharing and increased transparency. We want to stop being the very imperfect data mule between providers, right? It cannot depend on us to figure out, us as consumers, to figure out how we mix and match all the information across all the different platforms, and to make sure that our providers have all the information that they need, which is not the case right now. And imagine what that's going to look like when we're also now wanting to include very important social determinants of health information, right? So we need to make sure that we have all of, not just the privacy, which is what a lot of us think about when we're in the kind of data ecosystem. We also have to think about non-discrimination protections. And I thought there were a lot of questions in today's chat about how do we address non-discrimination when we understand that the iceberg of health data is so enormous. So it is essential that we include guardrails and checkpoints to protect them. Next slide. There is a better path that we can take that creates a health equity virtuous cycle. And this is a exclusive preview of a report that, a tool that we're going to be unveiling in the next several weeks about how we ensure that we are building, instead of a race to the bottom and making and using data and research in ways for policy and advocacy that are reifying and reinforcing existing inequities, how do we instead interrogate different decision points to make sure that we are we're designing, right? Equity by design. We are designing better systems, and that creates a virtuous cycle. So that requires that we surface these decision points and insert the patient and consumer voice and their full participation throughout. We need to stop thinking about that we are doing things for patients and families. We need to think about how we do things with patients and families, because guess what? Individuals and patients and families are the ones that actually understand best what their limitations are, what their unmet social needs are. They know how social needs limit their ability to get and stay healthy. They understand that it's a question not always of making better choices, but actually having good choices to begin with. That is not something that patients need to be educated about. What we need to figure out is how we can figure that out with patients and families and the communities that are most affected and closest to the pain. How do we make it easier to share this information among those who really could use that information in ways to improve communities' ability to have better choices and to have the resources that they need to live full, equitable, healthy lives? We also need to figure out how we do that without putting these communities at risk, especially in the context of, the race, all of the racially motivated, racially fraught structural inequities that continue to exist in our society. Let alone the changes, the winds of change when it comes to how policymakers want to use certain data. We are really excited that just a couple of days ago, for example, the public charge rule was struck down by federal courts. We know, those of us who work with immigrant communities, that public charge was a huge point of pain and fear for a lot of communities. That meant that even citizen children, for example, were being pulled out of food assistance and Medicaid and other services because of this fear of what would happen in terms of public charge with potentially other members of the family, including legally present members of the family who might have, whether they can get their visa, their permanent residency change into citizenship questioned, right? Let alone the fear of deportation of other members of the family. We need to make sure that the safeguards that we are putting into place protects people from whether Child Protective Services are going to intervene if there are questions about the ability to feed your family. We need to make sure that people are protected from ICE. And the best way of doing that is making sure that at every step of this cycle, we are including not just the consumer experts that, like us, so that can help, tie together and bridge the needs and priorities as expressed by individuals and families and communities who have been, for most of history, left out of the benefits of technology or otherwise hurt by technology. We also need to make sure that those voices, that we're not just like being their translators. We need to make sure that we are making and holding space and bringing in those authentic lived experience voices so that we can make sure that we are actually designing for equity in all of this work. Thank you very much. Next slide. This has been a real privilege. I'm very happy to continue to share our information. I know that we actually have a recent report on digital health and women's health that we are going to distribute, and please stay tuned for the Health Equity Decision Points tool that we expect to have out by the end of the month. Happy to take any questions. Here's my information if anybody wants to reach out to me for any follow-up. This has been a real privilege. Thank you very much.
Great, Cincy. Thank you so much. I am going to go ahead. Let me check the Q&A to see. I think. One question? Do you have time for one question?
Sure.
Okay, great. How can we avoid exacerbating inequities when implementing consumer-mediated data exchange? So these are the apps or other technologies that are, used at the patient's direction to sort of send information from point A to point B.
Yeah, that's an excellent question, and I think that there are two things that I would answer to that. One is, first of all, let's be very clear about the limitations of like who actually has access to that kind of technology. It is amazing and fantastic that we have Fitbits and Apple Watches and all of these apps and smartphones. But we need to make sure that as we design systems, we aren't only designing it for people who actually have access to that technology, right? That's the first thing that I think is always important for me to bring up in these conversations. But the second piece is really like, none of us, I would hazard to guess that none of us actually read the privacy statements that we need to check off for using any of the apps that we have on our phones, right? Like those are 12 pages long or more than that. They're like dozens and dozens of pages long. They take at least 15 minutes to read, and they're written at a level of like, you have to be a graduate student to actually understand the vocabulary, right? So we need to not make it that hard. We need to make sure that the systems themselves are designed so that there are the guardrails that are needed. And I think that involves having to get the FCC involved, right? It's not just what can, you know, the HHS and like the healthcare system do. This is beyond that, right? So it's about, you know, tracking what we were hearing earlier, like how many times do you get up to go to the bathroom being tracked? How many times, you know, how you're walking around, where you're checking, whether you're checking in on a bar, like that's like a real big brother scary proposition for a lot of people. And individuals, an individual person, an individual family, an individual health system, or even an individual, you know, even the healthcare sector as a whole does not have the power and ability to be able to design, develop, and implement those protections and guardrails.
Great. Well, thank you again for speaking with us. We will, for those of you listening, we will be making some of the national partnerships resources and materials available after the event, including these slides, but also some of the other tools that Cincy mentioned. So thank you again, and we really appreciate the time.
Thank you.
So at this point, we are at the conclusion of our event, and just a couple housekeeping notes before we drop off. First of all, thank you for sticking with us for the full 3 hours. We hope you found this program to be informative, and you know, we hope to continue the conversation that we started on Twitter at HIT Roundtable. We will also, as I mentioned at the outset of the event, be posting a recording and other materials on our website. We will send an email out to all of the registered participants after the event with the link to that and sort of a recap from the day's event with links to other events. We are planning on following up today's discussion with a white paper. So we will ensure that everyone that participated here today has a copy of that. And again, follow us on Twitter for additional updates about the timing of that release and other information. So my contact information is here on the screen. Feel free to reach out. We, again, really appreciate everyone's time and attention for a very important issue today. Thank you again to our host committee, all of our speakers, and everyone who helped sort of make this event happen today. It you know, takes a village. So we appreciate everyone lending their time and thoughts and resources to the effort here. So thank you again for joining. We will be in touch over email. Again, please don't hesitate to reach out either on Twitter or you shoot me an email. Thanks, and have a great day.